Welcome to the Iowa Cancer Consortium 2023 spring meeting. My name is Kelly Wells-Sittig, and my pronouns are she and her, and I have the pleasure of serving as the executive director for the consortium. As we start to get settled in, we ask that you would please take a moment to introduce yourself in the chat if you're able. We also encourage you to chat with each other throughout today's meeting, ask questions, share resources, react to what you're learning from our speakers. We hope this will be a conversational day. One thing our network is really great at is sharing information, learning from each other, and today is no exception to that. And then if you would help us with, for attendance and discussion purposes, if you hover over your own picture, there should be, or your name, if your camera is not on, there should be 3 dots above your name. Would you click on those 3 dots, select rename, and rename yourself with your full name, your pronouns, and your organization, so that we can have a great discussion and we can take attendance a little bit better. And also that'll help partners here connect with you and others during the morning and afternoon. As many of you know, this February, the Iowa Cancer Registry released its Cancer in Iowa report, which contained some pretty startling statistics, including that Iowa has the 2nd highest overall cancer incidence rate in the US. We're going to hear a little bit more about this from Dr. Sarah Nash here in a bit, but I mention it now because I think that we can all agree that it's extra important now more than ever that collaboration is a standard tool in our cancer control toolbox. Things really won't get better unless we work together, share ideas, share knowledge, share resources. When I think about the strength of our network, I often think about a quote that I think a lot of us have probably heard from Helen Keller, that's alone we can do so little, and together we can do so much. And that's certainly pertinent, but I also want to share another quote that I love. And I think about with the consortium, but also just in my daily life. And this is from maybe someone a little less famous, although maybe not, than Helen Keller, Amy Poehler. We're big fans of Parks and Rec over here at the consortium office. But Amy Poehler said, find a group of people who challenge and inspire you, spend a lot of time with them, and it will change your life. And I think this is so pertinent to our spring meeting today and all of the work that the consortium does. We are so lucky that right now we have 580 members of the Iowa Cancer Consortium. So this is great news. By being part of this coalition, you are already connected to 580 other people who can challenge you and inspire you, and who happen to also really care about cancer control and cancer in Iowa. And right now you're in the virtual presence of, it looks like 85 of them. So we've got a great network here today. I urge you to take advantage of it. I urge you to connect with people who challenge and inspire you throughout the day, but then also beyond. Additionally, 64 organizational members have currently chosen to formally align with collaborative cancer control efforts in Iowa. And I know we're going to have some links being dropped in the chat, they already are, where you can learn more about who our organizational members are and how you can become an organizational member if you're interested. There are lots of reasons that people find their way to the Iowa Cancer Consortium and that organizations find their way to the Iowa Cancer Consortium, but we can be confident that whatever the reason in this moment, it's a reflection of the collective interest that we all have in working together to reduce the burden of cancer in Iowa. And I get to tell you just a little bit about how these 500 plus people have done so much important work over the past year. If you saw our recently released 2022 annual report, you got a picture of what's been happening. And don't worry if you haven't seen it, because I know that link is going to be dropped in the chat as well. So you sure can, and we'll share it out afterwards as well. If you did see the report, you would have seen that we had 8 implementation grantees who put implementation grant dollars to work to carry out strategies and priorities from the Iowa Cancer Plan in really unique and important ways in their communities and in organizations across the state. Their projects addressed HPV vaccination uptake, mental health, colorectal and breast screening for vulnerable populations, lodging for cancer patients and caregivers, genetic testing, and even using writing as a healing art. You'll also read in the annual report that members shared their cancer experiences in 5 new Iowa Cancer Plan videos that are again highlighted in the annual report. I know we've mentioned these videos before, but we want to remind you over and over that these are available for you to reference and share as a really lovely way of showing the intersection of cancer experiences, the experiences of cancer control professionals, practitioners, advocates, and really what it is like, what cancer is like in the state of Iowa. I'm also really glad to say that many of them are joining us today. So you are, again, talking about being in the presence of people who inspire and make us excited about our work. Many of them are here today, and I hope you're able to connect with them. This report went out to state policy leaders last week and is available online, as you know, because you already have the link. So if you haven't read it, I encourage you to do that. And of course, a big story from the past year for the Iowa Cancer Consortium is the release of the new Iowa Cancer Plan. This plan was developed and led by a steering committee of Iowa Cancer Consortium members, and it included the input of numerous Iowans. The Iowa Cancer Plan is meant to be a blueprint for cancer control in Iowa. And I'm just so pleased to say that once again, this version of the plan leads with equity and intersectionality at its heart. A reminder that we like to share is that the Iowa Cancer Plan is really not meant for the Iowa Cancer Consortium to accomplish alone. Rather, it serves as a guide to provide direction and support for those who want to work collectively, like a coalition like ours, to accomplish the goals and strategies outlined in the plan. The plan is considered a living document, and we have the ability to update now as the cancer landscape changes, because this version of the plan lives online. And if you haven't checked it out, I hope you will do that. We will, if we have not already, put the link in the chat. We want your feedback. Again, this is a plan for our state, for everyone advocating for, working in cancer control, for us to accomplish and address together. And then hopefully you've seen the release of an exciting new network that's the product of the Iowa Cancer Consortium's Rural Work Group. The Iowa Oncology Navigation Network, or ION as we call it, is a members-only web forum and directory. It's housed with the consortium, and it's for Iowa professionals who work as patient navigators, oncology social workers, cancer care coordinators, and in similar roles to relate peer-to-peer, share resources, ask questions, make professional connections. This is a perfect example of a way that the consortium is trying to make space for us to be in each other's presence, virtual or otherwise, to learn from each other, inspire each other, share resources, and ultimately impact cancer control. If you're interested in becoming a member of ION, first, you have to be a member of the Iowa Cancer Consortium, which many of you are, and you can do that for $0. One of our staff members will be happy to tell you more about our different membership options. You can then email staff@canceroiowa.org to request to be added to ION. We really have limited this group to individuals who work as patient navigators, oncology social workers, cancer care coordinators, and similar roles. And we really hope and expect that this will help them connect and better serve Iowans who are facing cancer. And the link in the chat will direct you to somewhere where you can learn more. We also want to let you know that our community sunscreen program is open right now in case you haven't heard of it and want to take advantage. In an effort to increase sunscreen use and decrease incidence of sunburn, which of course can lead to skin cancer, the consortium each year distributes 50 gallons of SPF 30 sunscreen across Iowa for the summer. Applications for this are very simple. They're due on May 8th, so there's time. If you have a community project or program or event where you would like to make sunscreen available, email staff at canceroiowa.org for information, or there will be a link in the chat for this. And then very quickly, we want to introduce you to some not so new faces, but they're at least new since the last time we had a spring meeting. We've had 4 new board members join the consortium since we all met last for the spring meeting. Kristen Sewell has joined as our treasurer. Dee Hum, Lori Pietig, and Sarah Turnez have also joined the board of directors. And I think probably many of them, though I don't have my participants list pulled up, are on today if you'd like to chat with them. I know they'd be happy to talk to you about the consortium or your work and exchange ideas. And then we want to give a really warm welcome to 2 new staff members who have joined since we all met last for the spring meeting. Abby Batterson is our new communications coordinator, and Caroline Powell is our CDC PHAP, or Public Health Associate. She is serving us for 2 years as an outreach coordinator. We're super glad to have these 2 on our team. They're wonderful and have already brought so much to the organization. And if you haven't interacted with them yet, you will soon, and I know you'll be glad to. Now, speaking of people who inspire you and who have great resources and ideas, it's now my privilege to introduce Consortium President, Dr. Mary Charlton. Mary is an associate professor in the epidemiology department at the University of Iowa College of Public Health and is the director and principal investigator for the Iowa Cancer Registry. Welcome, Mary.
Thank you so much for the warm welcome. And I think I got the good news today. I'm actually a full professor as of today. I have made it, finally made it through the entire gauntlet of academia. So happy to have reached that milestone. Thank you for the introduction, and thank you everybody for taking the time to attend the spring meeting today. And Kelly shared so many great reasons for celebration and to have you all here, and the number of our members and the engagement that we're getting from everybody. But as she kind of alluded to earlier, sort of darkening the mood a little bit, I just wanted to reiterate a little bit of the findings from our Cancer in Iowa report in 2023. Thanks to a weird little story on Yahoo News that Katie Jones from Iowa Health and Human Services forwarded to us, kind of sent us down the path of realizing that Iowa is in fact has the highest, second highest cancer incidence in the United States based on the most recent data available for all the states, which is from 2015 to 2019. Behind only Kentucky, which is, is located in a tobacco belt, has really high smoking rates. So we're kind of, it was surprising to me, and I've gotten lots of emails, lots and lots of emails from people around the state saying, maybe we shouldn't be surprised considering some of the risk factors that we have in Iowa, different things, but just the point of that is lots of interest from people around the state about how this can be and how we can turn this around. Also concerning was that we were the only state in that time period that had a significantly increasing cancer trend. Every other state in the country had a flat trend or an actual decreased cancer trend over that 5-year time period. So I think it makes the work that we're doing more important than ever to try and figure out what's happening and what we can do about it. And as Kelly said, Dr. Nash will take a deeper dive into these numbers from the report and share those with people. So we're really excited that you're all attending and interested in hearing about our findings from the report. Policy changes are one big way that we can help reduce our state's cancer rates. And Jackie will talk about this in her legislative update. And just again, hopefully the report reaffirms how important that policy work is and what we need to be doing to protect the health of our state. Lung cancer continues to be the #1 cause of cancer-related deaths in Iowa, accounting for 1 out of every 4 cancer deaths. But we know there's ways to prevent it and to detect it earlier, like our panelists will share in their session about that. And we need to have a continued commitment to addressing health disparities, especially for cancers like prostate cancer that affect Iowa's Black population at a higher and deadlier rate, which Bridget, Omar, and Dr. Rosa will discuss. So my hope is that we'll all come away from this meeting energized and with more tools and partners to continue our important work and really turn it around and get Iowa out of this top 2 list and get us going in the direction that we can all feel good about, and that we know will protect the health of our fellow Iowans and our children and our environment and everything around us. So with that, I'm delighted to introduce our first speaker, Dr. Sarah Nash, who I always like to tell everybody was my greatest recruiting feat in all of my life. I recruited her from Alaska to move to Iowa. She had never been here before. She came sight unseen during the pandemic and has taken the state and the registry and the university by storm. And we're so lucky to have her. Sarah's an assistant professor in the Department of Epidemiology at the University of Iowa College of Public Health and director of research for the Iowa Cancer Registry. So welcome, Sarah, again. So glad that you're here and thankful that you're giving this presentation today. So take it away.
Thank you, Mary. That was a really great introduction to what I'm going to be talking about today. So hi to those of you who I don't know. I think I recognize many of the names on the list. As Mary said, I'm Sarah. I'm a relatively new assistant professor to the University of Iowa. And today I'm going to be talking to you as my role as Director of Research, Analytics, and Dissemination at the Iowa Cancer Registry, and I'm going to be sharing the highlights from the Cancer in Iowa report. So next, I forgot that I'm not driving this bus, Kelly. Next slide, thank you. So here's what we'll cover. We'll talk about what do you need to know from the Cancer in Iowa report 2023. Sorry, my vacuum is going off behind me and it's very distracting. I'm going to take 1 second to turn it off. So we'll talk about what are the things you need to know from the Cancer in Iowa report 2023. And what I'll do is I will walk you through some of the figures and some of the data that we present in the report. So for those of you who've seen the report, some of this might be familiar to you. And for those of you who haven't seen the report, hopefully this will give you a little bit of a walkthrough as to kind of what you'll find in that report. Then I'm going to tell you a little bit about some recent information that we've pulled together on oropharyngeal cancer. So the Iowa Cancer Registry has been thinking and is diving into the kind of one-page infographic business. And so oropharyngeal cancer was our first kind of focus topic. And so I'll be sharing with you some of the graphics from our one-pager that is on the horizon of being released immediately. And also with the call to, if you have topics that you'd like to see covered in these one pages, please go ahead and share that with Mary, with myself, with Kelly, or any of the ICC team, and we'll think about putting that together for you as soon as we're able. And then I'll end with just some information on how you can learn more about all of the data that I'll be sharing with you today. And then we'll have time for questions and discussion. I'm anticipating a lot of time for questions and discussion because we're running a little early. And I'll also invite Mary to kind of come and share the stage with me for those questions as well. So next slide, please, Kelly. So for those of you, I'm sure all of you are familiar, but for those of you who are unfamiliar, every year the Iowa Cancer Registry puts out an annual report. This year, we are celebrating 50 years of collecting cancer surveillance data for Iowans, which is just super exciting. So every year in the report, we present new cancer cases, estimates for new cancer cases and deaths, as well as the number of survivors we currently have living in Iowa. And you'll see that this year is no different. And we also every year have a special middle section where we talk about a different topic each year. So we've covered ovarian cancer last year as we were kind of coming back from COVID-related medical shutdowns. We talked about screening and the importance of getting folks back into their cancer screening routines. And then we've also covered wide range of different topics. And this year, also thanks to Katie Jones, I think she's been a bit of a troublemaker, or maybe not, that's not the right word, but in a good way. She's been helping us at the Cancer Registry really focus on some things. We decided to focus on the 50 years celebration. So in here, we present 50 years of cancer prevention and control milestones. I'm not going to talk about those today because I'm mostly going to focus on data, but if you're interested in some of the milestones that have occurred in the last 50 years in Iowa and nationally in terms of cancer surveillance, cancer prevention and control, we have those in the report. And then we have 50 years of cancer data, and this is mainly what I'll spend. Thanks, Katie. Katie says, I try to help. You do an excellent job. Thank you, Katie. And so here's where I'll spend most of my time here today is on the data piece. So we'll talk a little bit about incidence, mortality and survival trends. We'll talk about disparities, and we've got information on risk factor and protective factor prevalence in Iowa as well. Thank you, Liz, for posting the Cancer in Iowa report. So I don't know if these slides will be shared. If they are, there's a hyperlink to the report, as well as Liz just shared that link in the chat. So if you're interested in looking at the report, you can find it online. And we do have a few hard copies. If anybody wants us to send you a hard copy, just send me an email. Next slide, please, Kelly. So what I wanted to do today is just really distill the information in the report down to what are your need to knows. So the first thing that Mary already shared with us is that Iowa ranks #2 in the US for cancer incidence, behind only Kentucky. Among our leading cancers, we are 15th for breast, 7th for colorectal, and 16th for prostate in the nation. Next slide, please. And here's some other cancers that we have in Iowa that also have increasing rates and kind of where we sit in terms of our national ranking. So oral cavity and pharynx, we have an increasing rate. We'll see some data on that in a few slides. And for that, we rank first among the 50 states. Leukemia, we rank second, melanoma fifth, and so on and so forth. So you can kind of get a little bit of a sense of where our cancer rates are going currently in Iowa. Next slide, please, Kelly. Okay, so more on the topic of how our cancer rates are increasing. So as Mary again shared, Iowa is the only state in the US with a statistically significant increase in our most recent 5 years of data. So every other state either has rates that are stable or falling. And in this figure here, which all of my figures, as I said, are taken from the report to kind of give you a sense of kind of what the report looks like and maybe orient you if you're kind of new to reading the report and you're just going through it for the first time. So this figure here I'm showing you shows the incidence and mortality for all cancer sites together, age-adjusted incidence and mortality. And you can see that in the solid lines, we have the Iowa data, and in the dashed lines, we have data from the other NCI surveillance, epidemiology, and end results registries. And so this is kind of our national comparison here in the dashed line. And what you can see, first of all, in the blue is that Iowa's cancer rates are increasing where we see the rates in other states decreasing or remaining relatively stable. We also have substantially higher incidence relative to that national average. And the same is also true of mortality. So where we do see our mortality going down in Iowa, we still do see a difference whereby Iowa has higher cancer mortality than the SEER average. Next slide, please, Kelly. All right, and I wanted to then show you how the pattern varies by cancer site. So this is a fairly complicated figure, but let's see if I can help walk you through it. So what we're showing you on the y-axis here is the age-adjusted cancer rate per 100,000 population. And on the x-axis, we've got Iowa's leading cancers. So we're showing you information by each cancer site as opposed to having them all together. And then what we're seeing here is over time, from left to right within each cancer site, we're going through each decade. So from the 70s, 80s, 90s, 2000s, 2010s. In the blue bars, so we've got stacked bar, and in the blue piece of that, we're talking about incidence, which is the number of new cancers. And in the red piece, we're talking about mortality, which is cancer deaths. And so there's a lot of different information that you can take from this figure. But what you can see for many cancer sites is that our rates are either increasing over time or are increasing and then becoming stable. So let's take breast cancer, for example. The rates increased from the 70s, 80s, and 90s and have been relatively stable since then. Prostate cancer, we see an increase in incidence and then a decline. Similar for lung. Colorectal incidence is declining. The pattern is a little bit more different for mortality. So in some ways, we don't see those same increases in some cancer sites, but we are generally now seeing a decline in some cancer sites for mortality. So again, this is a fairly complex figure. I'm happy to chat about it more if anybody wants to really take a deep dive, but it is, again, on the report if you want to look at it a little bit more closely as well. Next slide, please, Kelly. So we also wanted to take a little bit of a look at cancer survival. So we estimate that there are currently more than 164,000 cancer survivors in Iowa. And we are interested in this because this provides us with information to really support this growing number of survivors. It may help us determine our needs around survivorship care, survivorship programs, and really help us identify different needs for this group. So what we're showing you here is actually the proportion of people surviving 5 years after their diagnosis. And this is, for most, every single cancer, this is great news. What we're seeing is that the proportion of people who are alive 5 years after their diagnosis is increasing. So similar to the last figure, we've got our bars, which show change over time. So from the lighter to the darker blue, we've got, again, 70s, 80s, 90s, 2000s, and 2010s. And what you can see is that over time, these bars are getting taller for most of these cancer sites here. And what that means is that for almost all of these leading cancers in Iowa, the number of people who are surviving, the proportion of people who are surviving their cancer diagnosis 5 years after their diagnosis is getting higher. And some of these increases have been really large. Let's take a look, for example, here at leukemia, which is kind of 2/3 of the way down this figure. Sorry, I don't think I have my cursor to show you here. But you can see for leukemia, the increase in survival, it used to be in the 70s, just about 30% of people were still alive 5 years after their cancer diagnosis. And today we're looking at approximately 70% of people still alive 5 years after their diagnosis. So this is really good news in terms of the number and the proportion of people that are surviving their cancers. Oh, let's see what Rachel has to say. There's more survivors than the population of Cedar Rapids. Wow, that's cool. Thank you, Rachel. I did not know the population of Cedar Rapids, so I love that. Next slide, please, Kelly. All right, and one of the other things that we looked at in terms of data are racial disparities over time. So I'm going to show you some data for these in the next couple of slides, but just to give you a little bit of an intro, by race, Iowa ranks 4th in overall age-adjusted cancer incidence for our non-Hispanic white population, 2nd for our non-Hispanic Black population, 35th for Hispanic, and 14th for Asian Pacific Islanders, and 9th for American Indian Alaska Native populations. So in particular, we've highlighted this, the statistic for our non-Hispanic Black population, because I think this indicates an area where we could really focus some of our efforts in terms of reducing disparities. Next slide, please, Kelly. So I'm going to walk you through this slide. So these are figures from the report, and we'll see a couple of different slides that look like this, different cancer sites. And what we're showing you here is for non-Hispanic Black and non-Hispanic White, incidence rate per 100,000 on the top set of bars, and on the bottom set of bars, the mortality rate per 100,000. And what we're seeing is how these incidence and mortality rates have changed over the last 50 years. So let's walk through this for prostate cancer. We can see that a couple of things here. In terms of incidence, we can see that prostate cancer incidence is substantially higher among our Black population compared to our white population. And by looking at the length of that arrow there, we can see that the increase over the past 50 years of cancer surveillance has been substantially larger for our Black population compared to our white population. Now let's flip down to mortality. So this is the bottom set of information here, and we've got the kind of dashed blue arrows instead of the solid blue arrows. And so what we're seeing here is that for both Black and white, we've seen a decline in mortality. The mortality is still substantially higher among our Black population than it is among our white population, and the length of the arrow indicating the amount of decline in the mortality rate is substantially larger for our white population than for our Black population. I've been working a little bit with, and I see some folks that are actually online here today, with the Black Hawk County Steering Committee through the Holden Comprehensive Cancer Center's community outreach and engagement with Kelly and others. And I know that this is a real concern, and this is maybe some way that the data can help us kind of unpick how and why our communities are interested and concerned in some of these cancers in their community. Next slide, please, Kelly. So the next one is focused on breast cancer. And you can see here, at the top is exactly the same format. Here you can see that the incidence of breast cancer is slightly higher among Iowa's white population compared to our Black population. And the amount of increase from 1973 to 2019 is about the same in both populations. However, what we see on the flip side with mortality is that the mortality rate is actually just ever so slightly higher among our Black population than it is among our white population. But fortunately, we have seen a fairly large decline in mortality rates for both populations. Next slide, please, Kelly. And then finally, we focused on uterine cancer. And here again, on the top, we see incidence. On the bottom, we see mortality. And you can see that from 1973 to 2019, the increase in incidence among our Black population is actually a little bit larger than among our white population. Even though the rate is now slightly lower among our Black population, the degree to which that has changed over time is different between the two groups. Again, here you can see that the mortality rate too is different between the two groups. So the mortality rate is higher among Iowa's Black population, as well as the degree of change over time is slightly larger among Iowa's Black population compared to our white population. Now, I should say some of the questions that we often get when we're looking at data and when we're looking at trends over time is, why is this happening? And I think one of the things that I find so interesting about the registry and the data that we have is that it can tell us that something is happening, but it can't really tell us why. So this is where I really want to open us up to a discussion about, what do you think is happening in your community that could result in changes to incidence and mortality rates, not just for uterine cancer, but for all of the data that I've shown you here today. And that I think really kind of starts us exploring the why. And I think that's a great conversation for us to have as a cancer control community. Next slide, please, Kelly. And getting into the why, here's what we presented in the report about risk factor prevalence. And so this kind of tells us, kind of linking those cancer registry data, the what and the how to the why, is these risk factor information. So we use data from the behavioral risk factor surveillance system really to dig into some of these risk and protective factors for cancer. So on the left here, I'm showing you data for the prevalence of obesity, operationalized as having a body mass index greater than 30 kilograms per meter squared. And you can see that the prevalence of having a BMI over 30 is slightly higher among Iowa compared to the US. Weight, we know, is not a generally good marker of health in itself, but we do know that there have been some links between obesity and increased risk for certain cancers. But what we really can focus on when we think about obesity is focusing on healthful diet and exercise. So on the right here, we're showing you the prevalence of folks who consume both 2+ fruits and 3+ vegetables per day in 2021. We know that eating fruits and veggies is a really important piece of a healthful diet. And so that's why we're interested. That's why we put this one in our report. And we can see that a very, very small proportion of individuals are meeting this guideline to consume 2+ fruits and 3+ veggies daily. And so here we find a real opportunity to really engage with healthy eating behaviors among across Iowa and among Iowa's population. Next slide, please, Kelly. In terms of physical activity, again, we know physical activity is really great for you. It has a multitude of health benefits from cardiovascular health, mental health, and also in terms of cancer prevention. So really important that we're promoting physical activity and getting our communities to engage in physical activity. Here on the left, we're showing you in the pink box, we're showing you the proportion of individuals who met physical activity guidelines. So the CDC guidelines suggest that we should be engaging in 150 minutes of moderate to vigorous physical aerobic activity. Sorry, that's a bit of a mouthful, as well as 2 days of muscle strengthening per week. So often we forget that second piece, but that's also really important. So with that, we're thinking about resistance training, we're thinking about lifting weights. And this is really important, especially for folks as we age. So we really want to ensure that folks are engaging in that physical activity. And we can see that the proportion of people who are meeting those guidelines is relatively low. It's about 1/5 of Iowans are meeting those guidelines, slightly lower than the US average. And this, again, can give us kind of opportunities for prevention. And I know that both healthy eating and physical activity feature prominently in the Iowa Cancer Plan. So this gives us some data to really start thinking about how we can help our communities and kind of address those barriers to engaging in healthy eating and physical activity and really build on the resiliencies that already exist in our community and that are helping these people, these 20% of people already engage with that behavior. On the right, we're looking at alcohol. So studies have shown that drinking alcohol is linked to an increased risk of several different cancers, and we'll talk specifically about oral cavity cancer in a couple of slides. But we can see here we're showing you 2 different pieces of information about alcohol use. On the left, we're showing binge drinking. So for females, this is defined as 4, and for males, 5 drinks on one occasion in the past 30 days. And on the left, we're showing you heavy drinking. This is thinking about drinking over the course of your week. So for females is defined as 8+ drinks and for males as 15. And you can see that particularly for binge drinking, the proportion of Iowans that report binge drinking is substantially higher than the US average, and slightly higher proportion who report heavy drinking too. And so this, again, is another way that we can think about engaging in cancer prevention behaviors in terms of reducing exposure to alcohol. Next slide, please, Kelly. Here on the right, we have cigarette smoking and tobacco use. So we know that tobacco use is strongly linked to increased risk of many different types of cancer. And it accounts for almost 90% of all lung cancers and about 30% of all cancer deaths in the US. I feel like we have made really good strides nationally and within Iowa over time to reduce prevalence of tobacco use. And so we see it now about 15% of adults currently use tobacco. We do have in the report, although I'm not showing it you here today, we do have a really nice figure that shows both prevalence of, I believe it shows prevalence of tobacco use over time, as well as incidence and mortality from lung cancer. So we have a little box that focuses on lung cancer if you're interested in looking more, but there's some really strong data to show that as tobacco use drops, so does lung cancer and mortality. In terms of infection, we really wanted to focus here on HPV and Hep B. We know in particular that promoting HPV vaccination, again, I'll talk a little bit about this when we think about oropharyngeal cancers, is really important. It's really important to be promoting this vaccine among our youth, linked to risk of many different cancers that we've shown here in the box. And we can see that approximately 60% of both national and Iowan adolescents are vaccinated. Hep B, the proportion is slightly higher. And hepatitis B increases one's risk for liver cancer. So really important to be thinking about what infections could be linked to increased risk of cancer, and where there is a vaccine, making sure that we're promoting that in our communities. Next slide, please, Kelly. Now, we don't have information on these in terms of prevalence and birth data, but we also wanted to bring attention to radiation. So in particular, ultraviolet radiation, and you heard from Kelly about the Cancer Consortium's wonderful skin protection, UV sunscreen promoting programs. And I know, Kelly, that I have engaged with the Iowa Cancer Consortium sunscreen station at Big Grove here in Iowa City. I always love to see that. And I always make a point of mentioning it to people how excited I am that they have one of those stations, so that they keep doing it. And so we can think both about ultraviolet radiation, as well as we also mention here radon gas, which is the leading cause of non-smoking related lung cancer. And I think that has gained a lot of attention here in Iowa recently with the Gale Orcutt bill. And then we also mention here environmental risk factors, which I think part of the issue with these is that we know a lot less about them in terms of their risk and how they are linked to different cancers. But we can think about different things in our environment that have been linked to cancers in terms of environmental exposures, pesticides, pollutants, those kinds of things. Again, that's something that we maybe know a little bit less about, but we have some great colleagues over in environmental health who are really, really wonderful and kind of chat with Mary and I about some of these things. Next slide, please, Kelly. So now I wanted to kind of flip over to our focus on oropharyngeal cancer. So as I said, we have an upcoming Iowa Cancer Registry one-pager. We had a wonderful practicum student called Anya, who's been working with us through the spring semester, who's been helping us both put together this oropharyngeal cancer one-pager, as well as providing us with a template that we can use for future one-pagers. So if you have a topic that you're interested in seeing information on in this format, please do let us know. And so here's where we started. We know that Iowa's incidence rate for oral cavity and pharynx cancer is #1 in the nation, and it is rising faster than all other states. Next slide, please, Kelly. Here, for those who are unfamiliar, is a picture, a schematic of what we're talking about when we talk about oral cavity and pharynx cancers. And these are a subset of head and neck cancers. Part of the reason we wanted to do this is because April is Head and Neck Cancer Awareness Month. So as this gets released, this one-pager, and I think Kelly and the ICC are going to help us kind of distribute it. So please do use that if you are doing anything with Head and Neck Cancer Awareness Month. Next slide, please, Kelly. We know that in 2023, there'll be an estimated 620 new cases, 100 deaths, and almost 5,000 survivors in Iowa due to OCP cancers, oral cavity and pharynx cancers. Next. And these cancers are important not only because of the toll that they have in terms of morbidity and mortality for Iowa's population, but also in terms of things like quality of life. They can lead to trouble speaking, trouble swallowing, poor quality of life. Let's see what Katie has to add here. Yeah, talking about risk factors. Thank you, Katie. We have maybe high exposure to environmental risk factors. Thank you, Katie, for your feedback there. Next slide, please. Thank you. And so we also wanted to focus here in our one-pager on oropharyngeal, why these cancer rates are so high. And so we were able to break this down in terms of HPV and non-HPV related cancers. So what we're seeing here in the figure is in yellow, we have oral cavity and pharynx cancers. So we've got the incidence rate for Iowa in the solid line. The dashed line is other SEER registries, as I explained before. In the orange, we're looking at the non-HPV linked OCP cancers, and in blue, we're looking at the HPV linked cancers. And so what you can see here, if you focus particularly on this blue line here, we've really seen an uptick in Iowa over the last few years in terms of HPV linked oral cavity and pharynx cancers. So it's important to note that there still is a higher burden of non-HPV linked oral cavity and pharynx cancers. So we should still be focusing on things like tobacco and alcohol use, which are known risk factors for the non-HPV related cancers. But this also provides us an opportunity in terms of prevention to really thinking about how we can be thinking about HPV vaccination and really making sure that we're promoting it in our state. Next slide, please, Kelly. Building on that a little bit more, just to share information about these risk factors. So they include tobacco use, alcohol consumption, and HPV. Those are really kind of the big three that we think about. But also looking at unhealthy diet, lack of exercise, ultraviolet light, especially for lip cancers, and oral leukoplakia. I hope I'm pronouncing that correctly. Thank you for all the clinicians for putting up with my terrible clinical pronunciation. And importantly, in Iowa in 2021, males had higher rates of alcohol and tobacco use than females, along with lower rates of HPV vaccination, which may put that subset of our population at increased risk for these cancers. Next slide, please, Kelly. Next piece of the slide. In the one pager, we talk about ways to prevent these cancers. So I think this kind of feeds nicely from the previous box in terms of avoiding tobacco, limiting alcohol use, and making sure that we get the vaccine, as well as being physically active, using our sun protection, and avoid tanning beds. Next piece, please, Kelly. Early detection. So early detection, especially in terms of regular dental checkups. So if you think about it, your doctor's not often in your mouth, but your dentist, that's where they live. So we really think about having regular dental checkups. There are so many reasons to get your dental checkups, but oral cavity and pharynx cancer is among them. Next slide, please, Kelly. And then thinking also about bringing awareness to symptoms so that folks can think about what they should be considering and being aware of in terms of the symptoms. So unusual mouth bleeding, pain, neck mass, sore throat, and troubles chewing or swallowing. So this is all the information. I don't think there's another slide from this one pager. Can you? Thank you, Kelly. So this is all the information that we have on our kind of one pager that is actually two pages. I keep calling it the one pager, but it's 2 pages long. It has a front and a back. And so I think Kelly will be and her team will be helping us distribute this. So if you haven't seen it already, please kind of hold on the edge of your seats to see that come out from ICC. We're going to be working with ICC to both kind of put together some of these one pages as well as help distribute them. So if you have topics that you're interested in, if you want to get a hold of the one pager, they will be available on our website, but also we'll be working with ICC to kind of distribute them to you all. I wanted to finish with some information. And again, Kelly, please feel free to share these slides. I put some links in here. If you're looking to learn more, if you want more information on cancer data, I've given you a link to the Iowa Cancer Registry website. There you can find our Cancer in Iowa report, as well as for this year, as well as I'm not sure how many previous years, but I think it's over 10 previous years. So you can see all of those special sections we've done for the past decade or so. They're all on there. We have information on cancer maps. So I'm showing you here on the right some information on breast cancer risk probability from a cancer mapping project that we work with on with some folks from the College of Public Health, and these can kind of help us understand where hotspots might be for certain cancers. And then we have some interactive cancer maps on the website, which can help you if you're interested in kind of county level data on cancer incidence for your county or for how your county compares to other counties around the state. We also have some interactive cancer maps on the website. So it really is just a wonderful place that you can go and get a lot of data on cancer incidence and all different kinds of things from the camp. Thank you, Liz, for posting the website. So please do use our website as a resource, and we will be posting that one pager there shortly as well. So I think that's all I have in terms of data to present today. Happy to talk about questions. I just saw one come in. And I'll also invite, sorry to put you on the spot, Mary, but I know that you're great at being put on the spot. So I'll invite Mary to come back and share the stage with me, because she also is just a wealth of information in terms of cancer and cancer in Iowa. I see a question from Julie in terms of, she says, what in the report, is there any tracking of incidence of cancer based on professional work history? Unfortunately, that is not information that we collect within the registry, but we do have the agricultural health study, which is not on everybody, but is a study that can tell us a little bit about cancer risk, specifically among farmers. I know, Mary, is there anything you want to add about that study? Nope, she's saying no. But unfortunately, Julie, that occupation is not something that we collect within the cancer registry. What we really do is we collect information from the medical record. So we're really collecting that central medical information. So we don't have information on occupation. I also see a question from Laura about what is meant by the term other SEER registries? Are the national SEER registries drawn from all US states or only a limited number of states? Yeah, that's a really good question. So without wading into too much detail, there are currently 21 SEER registry states. Back in 1973, when the Iowa Cancer Registry started, there were 9. So we are one of 9 original registries that were included in this program. And the program has grown since that time to really include a much larger proportion of the country. Every single state in the country has a cancer registry. Some of them report to the CDC. Some of them report to the National Cancer Institute. And there's slight differences. I'm not going to delve into the differences between the two programs. Laura, I'm happy to talk about it offline if you're really interested. But when we're comparing to the SEER program, when we're going back to 1973, we're comparing to those other 9 registries that were included way back as the original cancer registries. And I'm going to try and list them off, and Mary, you can help me if I'm missing any. Iowa, Hawaii. Oh, goodness. I'm terrible on the spot.
I mean, Iowa, Hawaii, New Mexico, Kentucky, Louisiana, Connecticut. What are we forgetting? California, yep. Georgia.
Detroit was, yes. And get them all? I
think that's it. I don't think Idaho is in the most recent one. They're a newer one. So I think
so, we got them. And then we built up from those 9 to include registries, Texas, Idaho, who else is now? Alaska Native Tumor Registry is now included.
Illinois,
Massachusetts,
New York.
There we go. Thank you, Mary. So that was a long answer to a short question, Laura. I hope I got that.
Those registries are, though, supposed to, in theory, represent the U.S. population. They were chosen for specific reasons, and that they hold representative population. So they are supposed to be a reflection, even though they are not the whole. But the data where that Sarah mentioned that shows that we're number 2 in cancer incidence and have the only state with the rising cancer trends, that is from all 50 registries are included in that comparison.
Mary, we forgot one. Kentucky is the SEER registry.
Oh, did I not say Kentucky?
How did we forget Kentucky? Thank you, Rachel.
Yeah, thank
you can test
so
us
much
now with our map that Rachel just posted.
We have about 3 minutes left. If there are any questions, any other questions, you're welcome to drop it in the chat or come off of mute and ask your question of Dr. Nash and Dr. Charlton.
And if you have any questions after the fact, you're always welcome to email myself or Mary. So I'm Sarah-Nash, Mary-Charlton at uiowa.edu.
We can drop
And I would encourage everybody to share their report with maybe like their local city council and things like that. Like we've gotten emails, I think it's from somebody on this Clive City Council, gotten emails from Christina Bohannon, our state representative, just to really make sure that people, our policymakers, are aware of what's happening with our cancer incidents and how important it is to act now, which I think is a whole topic of another session that we have coming up, but just wanted to, please feel free to pass along our report to anyone you think could benefit from that information and as a decision maker that could use it to help turn things around.
I just wanted to say thank you so much for this work that you all are doing, and it's so interesting. And I was trying to share in my comment that just anecdotally, when I've been telling people, we have the second highest incident rate, a lot of people I've noticed, and the original Yahoo article that started all of this also sort of point at pesticides or environmental exposures. And I really like that in the report itself, it shows there's not one easy answer. I know, Mary, you've said this too when you were doing the River to River interview, I believe. There's not like one easy answer. It's not just tobacco. And that's why we're number 2, because we have really high tobacco rate, and a lot of the cancers we're high in is tobacco. It's not as clear cut as that. And there's not one easy answer. It's probably a variety of different things that we just have higher rates of a variety of risk factors. And so I do think it's so interesting to look at which specific cancers we have the higher rates in, like the oral pharyngeal cancers, and that's related to alcohol, tobacco, and HPV vaccination. And so looking at the risk factors for the specific types of cancer, I think is so interesting and important, but harder to communicate to people too. It's more nuanced, but I appreciate you guys trying to break some of that info down.
Yeah, thank you so much, Dr. Nash and Dr. Charlton. Just appreciate your knowledge and your time sharing it with us today. Thanks for being here, and thanks for putting your email addresses in the chat.
All right, welcome back, everybody. Hope you had a good, energizing break. My name is Liz Orton. My pronouns are she and her, and I am an outreach coordinator here at the Iowa Cancer Consortium. And I am pleased to introduce Jackie Cale. So Jackie will be doing our next session. Jackie serves as the Iowa Government Relations Director for the American Cancer Society Cancer Action Network, which is the advocacy affiliate of the American Cancer Society. She joined the organization in 2019 as Iowa's grassroots manager, working closely with cancer advocates and volunteers, uplifting their voices through public policy at the state and federal level. In her current role, she works closely with Iowa legislature, passing policies that will decrease the burden of cancer for all Iowans. Welcome, Jackie.
Thanks, Liz. And thank you to the Cancer Consortium for having me today. I am going to give a brief legislative update at the legislature. The 2023 session has not adjourned yet for the year. They are scheduled to wrap up this Friday. I don't think that that's going to happen, but wishful thinking, they can get everything accomplished in 2 days. We are still waiting for some budget bills to come out, but I'll do my best to give an update with what we have done so far this year. Next slide, Kelly. So for those of you who don't know, ACS CAN, the American Cancer Society Cancer Action Network, is the advocacy affiliate of the American Cancer Society. So we work with volunteers across the state and across the nation to attack cancer through state, federal, and local policies. We know that in order to reduce the burden of cancer, we have to tackle cancer through these public policy initiatives. For example, access to care, tobacco control policies, etc. And you can see that photo in the corner. That was our last day of action up at the Capitol, which was in 2020. I'm hopeful that 2024, we will be able to bring a large group of volunteers back to the Capitol to really make our voices heard. Next slide. So these are some of our state priorities that we went into 2023 with. Tobacco control is always a big bucket for us. This year, we particularly focused on expanding Iowa's smoke-free air law to include e-cigarettes and casinos. And then we are always thinking that, or we are always encouraging legislators to think about a policy that would increase the tobacco tax by $1.50 per pack. This year in particular was the 15th anniversary of the smoke-free air law going into effect. So we held a celebration up at the Capitol where we had former governor and U.S. Ambassador Terry Branstad come and speak to our lawmakers. He was a big component of smoke-free air 15 years ago, so it was great to hear him come and work with us and encourage the lawmakers to include e-cigarettes and casinos into that law. Another issue that we were really focused on going into the session was protecting Iowa Medicaid from harmful cuts. I'll go into that a little bit more on the next slide. And then we knew that the Medicaid unwinding was happening on April 1st. So we are continuing to monitor that. That will be a continual issue that we will be working with the department to make sure that they're getting the information out. Do we see anybody that, do we see any Iowans that are left without insurance, what those numbers look like? And then of course, appropriations. We have appropriations for a number of cancer priorities in the state. One of those being the breast and cervical cancer screening program, and then the other cessation program. So we want to ensure that those do not go through any cuts this session, which we are anticipating them to have. But it's, of course, we don't know what we're anticipating. Next slide. So those were some of our priorities going into session. This is done during session. So one policy that came up this year that we had to work against is Medicaid work requirements. So this policy in particular would require Medicaid recipients to complete 20 hours of work or community engagement activities as a condition of eligibility for Medicaid. It is an extremely burdensome policy to receive access to care. So we did everything in our power to defeat that legislation, and we were successful in that, which is really a huge testament to all of the people that shared their story, wrote an email to their legislator. We had, hundreds of conversations up at the Capitol with these legislators about how this policy would affect Iowans. In Arkansas, they implemented Medicaid work requirements, and within the 10 months that they were implemented, 18,000 enrollees lost coverage. One thing that the legislature did do this year was they created exemptions, one of those being for cancer patients. So we know that they are listening. Obviously, if you are going through cancer treatment, you aren't able to work that 20 hours a week, but you need access to healthcare. So they did include an exemption for people that would be going through cancer treatment. But we still have a huge issue with even just the reporting system. So you would have to report monthly that you are still in active treatment, you are no longer working. If you miss that reporting date, you would lose coverage, and you would be stuck with an astronomical cancer bill. So even with the exemptions that the legislature was proposing, we were still very much against this kind of policy. Arkansas shut down this policy when they implemented it. After 10 months, the court shut it down. Many of those 18,000 people that lost coverage many of them had an exemption. So we just know that this policy is extremely detrimental and it creates a huge access barrier to access. Another bill that came up was a bill to eliminate the Tobacco Commission. We fortunately were able to defeat that in the Senate. The Senate did not want to bring that policy forward, so we were able to defeat that. But I do anticipate both Medicaid work requirements and this Tobacco Commission bill coming back next year. So we'll be having to do a lot of work during the interim to ensure that we're having these conversations. So when we do have to fight these policies again in 2024, we're prepared. And then another bill that unfortunately is going to the governor's desk that we weren't prepared for was it eliminates the requirement for Iowa schools to teach about HPV and the HPV vaccine. So as we learned earlier, that's HPV is rising in Iowa, and so this is a very, very concerning bill. We worked closely with the Iowa Immunizes Coalition. We had lots of action alerts go out. This was wrapped up in more of the governor's priority to limit or to create a smaller government. So she was not interested in listing all of the pieces, listing HPV within the curriculum. Schools are still able to teach about HPV, but it will not be a requirement. And that was something that was unique about Iowa, was that it was part of health curriculum in the past. So moving forward, we'll be more aware of what we can do to improve HPV and access to the HPV vaccine moving forward. Next slide. So looking forward to 2024, we do anticipate Medicaid work requirements coming back. There's been actually a national push from the federal government to implement policies like these. So while we were able to kill it this year, I am afraid that they'll come back another year. And the bill essentially said, you know, we're going to keep introducing Medicaid work requirements until a new administration is in place. So it's something that we're very concerned about. We're monitoring it on a state and federal level. Iowa will have to renew Medicaid expansion next year. So that's something that we'll work with the state legislature on. Something I'm really excited about is we're hoping to have a bill that will expand access to biomarker testing. I know many of you probably have a little bit of knowledge about biomarker testing, but it really is the key to precision medicine and cancer patients getting the right treatment at the right time. So we want to ensure that all Iowans have access to biomarker testing, whether that's through a private or public payer. So that'll be our main priority for 2024, and we'll hope to engage a lot of our volunteers and a lot of our network within this issue. And then obviously we will focus on tobacco control, hopefully bring some of the bills back. There was a bill this year to include e-cigarettes in the smoke-free air law, but it did unfortunately not make funnel, so it died about halfway through the legislative session. So hopefully we'll be able to grow our coalition and find some new legislative champions. There's a lot of new legislators this year, so there was a lot more education that happened this year. Next slide. So how can you get involved? Looking forward to 2024, we really need stories. So if you yourself are going through treatment and you benefited from getting a biomarker test, many insurances do pay for it at this time. That's important as well. Have you benefited from it? Has your quality of life benefited from it? Those are all extremely important stories. Other stories that might be important looking forward to 2024 are, were you unable to work during treatment, or do you have a family member that wasn't able to work during treatment? Those stories are going to go really far when we're talking to legislators and when and if they bring up Medicaid work requirements again. Another thing is I'm going to share a link in the chat for our biomarker petition. Essentially, if you fill out the petition, you'll just be on our email list to get emails moving forward about what we're doing with biomarker testing and how we're interacting. We'll keep you in the loop as much as possible. I think we have about 26 people on the petition right now, and our goal is to get 100 people to sign on to the petition before the 2024 session begins, so we can give those to the legislature. I think we have over 100 people on. So if you're interested, really, you're just giving your email to make sure you're staying in. We won't spam you with anything, I promise. And I think that's pretty much all. 1 minute left. I'll go ahead and share that link.
Thank you, Jackie. All right, well, we are right at 1 o'clock. So if you do have any questions, maybe Jackie, you could put your email in the chat as well for folks to reach out to you. But thank you so much for sharing that update for us. I am now pleased to introduce our lung cancer panel. So moderating today will be Dr. Susanna Friemel. Dr. Friemel is the owner of Iowa Cancer Specialists in the Quad Cities. She is a board member of the Iowa Cancer Consortium and also the board president of the Iowa Oncology Society. So welcome, Dr. Friemel.
Thank you. Can you hear me, Liz?
Yes.
So our panelists today are Tabetha Gerdner, Lori Pietig, and Alissa McEowen. Each panelist will give you a 10-minute presentation about their area of expertise in lung cancer care in Iowa. Following the last presentation, we'll have a 15-minute Q&A session, so please enter your questions in the chat, or there will be time to come off mute during the Q&A session. Our first panelist is Tabetha Gerdner. Tabetha is the Quitline, Iowa Program Manager for the Iowa Department of Health and Human Services. Part of her work includes researching the e-cigarette industry, including brands, flavors, devices, and products. This research has assisted in the development of presentations on electronic cigarette devices and their harmful effects, which have been delivered to providers, educators, and youth audiences across the nation. One of Iowa HHS's newest cessation efforts, My Life, My Quit, is specifically designed for youths aged 13 through 17. Tabetha has managed the rollout of this program in Iowa, one of only a handful of states implementing this teen cessation program aimed at tobacco and vaping cessation. Welcome, Tabetha.
Good morning, everyone. Actually, it's good afternoon. Holy smokes. I didn't realize it's 1 o'clock. It's been a busy day already. So I'm really happy to be here. I'm going to get my share screen up. Liz, can you give me a thumbs up if you can see that? Perfect. Okay, so as she had said, I work with the Tobacco Youth Prevention and Control Division. We are a small but mighty team here at HHS working to reduce tobacco and nicotine use across the state of Iowa. So, and I know I only have 10 minutes today, and I would like to preface this with, normally I'm giving an hour-long presentation and I'm deep diving into all of the terrible things about tobacco, e-cigarettes, vaping, and all of the different populations that it disproportionately affects. So today you only get me for 10 minutes, and it's going to be very high-level, brief overview, but my contact information will be available for you to always reach out in the future, because I love talking about nicotine, I love talking about tobacco, and I love helping people have a better understanding of it. Okay, so let's dive in quick here. I like to start with some just quick facts about tobacco. This is just my grab you in, so you all know, I mean, obviously most people here already know that tobacco and nicotine is harmful, but let's talk quick about what it's doing in our state specifically. So we know that tobacco kills about 5,100 adults in Iowa each year. I would like to say that the CDC has not updated this number since 2014. So it's been 9 years. We're sure that it's probably more than this.
at this time. We know that also back in 2014, it harms roughly 55,000 kids in Iowa. So we're still kind of waiting for the CDC to update this number. We don't know when they'll do that. We ask every year. 1.49 billion are spent in healthcare costs in Iowa, which are directly caused by smoking. So when I say smoking, that's not inclusive of vaping. So this is just smoking. Also, the industry spends an estimated $106 million in Iowa alone just on marketing. Translate that to worldwide, it's about $1 million per hour. That's insanity. They have one of the largest marketing efforts in any product in the history of the world. And then 20.1% of Iowa high school students are using e-cigarettes. So those are just kind of the top facts here. We also know that tobacco is the leading preventable cause of death for Iowans. And for us here at HHS to achieve our initiatives, we follow, our program follows the CDC guidelines and best practices for comprehensive tobacco control programs. Those include of course, preventing the initiation of tobacco use among young people. I'm going to talk a little bit in a couple of slides about all of our different programs and how we address these initiatives, but these are kind of the 4 target areas. Of course, eliminating non-smokers' exposure to secondhand smoke, promoting quitting, and then identifying and eliminating those tobacco-related disparities among those certain population groups. And this year, specifically, we're working with the LGBTQ population and helping to reduce their tobacco use rates. And we've been very successful for the past year with that. So excited to share some data that'll be coming out later this fall. That's a little teaser on some information we'll be sharing soon. So here's just some of the successes that we've seen in tobacco control since 2000. Our smoking, which only includes cigarettes, rate is down among adults. Our youth smoking rates are down, tremendously. We've kind of eliminated smoking in terms of its appeal, to young folks, right? We know that cigarettes are just gross. They're nasty. If you talk to kids, they're like, "Ooh, I want nothing to do with that." Of course, they think vaping's really cool. And so it's going to take another, 10, 15 years for us to get that same social norm of gross. These things are harmful. They're hurting my body. I shouldn't be using them. But we still need some research to kind of help back that up. And then, of course, back in 2000, there really wasn't a smoke-free air law. Now, we're celebrating this year our 15 years of the Iowa smoke-free air law. I know the last person that was chatting about the new bill that, they're trying to get vaping devices included in that smoke-free air law. This, I think, is the 3rd year in a row that, the advocates have really been pushing for that. And we're hopefully in the next year or two that it just continuously get brought back up. But what we do here is, because it's not included as a state law, we work with those businesses to implement their own policies, right? So that you can't just walk into a Target and start using vaping devices because they have their own policy. Again, that's a presentation for another day and I'm easily distracted. So we'll just keep going on what I have here on this slide. We've also, with Quitline and now with My Life, My Quit, our youth program, we've made it easily and accessible to offer successful cessation services that are, available 24/7. And we give away a lot of free nicotine replacement therapy. Most of that's based on insurance status, but we're always happy to assist with Quitline. These are some of the programs that we are, working on. These are the programs that help facilitate those 4 target areas that I talked about before, which is the Smoke-Free Air Act. Kind of discussed that. Our Smoke-Free Homes program. This is a program that we work with landlords across the state, implementing smoke-free policies for not only their multifamily dwelling units, but also their single-family units. We're actually launching a survey right now that's in the field to find out how many, tenants, what their perceptions are about having smoke-free housing available. We have our tobacco-free, nicotine-free policy initiatives that I talked briefly about with our businesses, daycare, schools, of course. Our ISTEP program, which is our Iowa Students for Tobacco Education and Prevention. This is comprised of hundreds of youth across Iowa who come together to kind of rally against big tobacco and stand up to big tobacco. And we know that it's really important to have peer support. Our cessation programs, including the Quitline Iowa and My Life, My Quit. And then, of course, just educating on those nicotine and tobacco products. So we know that we've done a lot over the past 20 years, but with these new products constantly on the rise and marketing efforts and all of the things changing in the world of tobacco, we're just not done yet. So we have a lot to do. And with the rise of youth vaping, and it's now a national epidemic, which threatens to create a new generation of Americans who really are addicted to nicotine, it's just really important that we're continuing this work that we've done for the past 20 years, just directing it at a new product. So I want to talk briefly just about My Life, My Quit and Quitline. So My Life, My Quit was launched in 2019 with the goal of providing cessation programming for youth who are addicted to tobacco products. This kind of developed off of the Valley that was going in, mid to late 2019. My Life, My Quit is free to all youth, 13 to 17-year-olds. They get access to a quit coach. It's a text-based program. These coaches are dedicated youth coaches, so they kind of understand, what youth are experiencing. And we've seen a lot of success with this program over the last 3 years. And we're also implementing My Life, My Quit as an alternative to punitive measures in schools. So we're working with various schools across the state to kind of teach them, hey, this is an addiction to youth, and this is a different type of nicotine. This nicotine has benzoic acid in it and your bloodstream 2.7 times faster. It's addictive. We need to be able to help these kids, and this is how we're going to do that, by providing, that resource for them. And then, of course, Quitline, that's been around for 20 years, helping people in various program areas within Quitline. We do have various programs. We have our base program, which is our 5 calls. Then, of course, we have a behavioral health program. So if you, identify as living with a behavioral health condition, you get additional help, additional calls, and you also are eligible for additional NRT. We have our pregnancy program, My Pride and Joy, which is 9 calls. You get a dedicated female coach, and of course, NRT as well. There's also some incentives you can get. Our American Indian program, because we know it's important to talk about the difference of commercial tobacco versus sacred tobacco. And then our young adult program, again, those coming off that wave of e-cigarette use and helping them get help. Final slide. Oh my gosh, I feel like I'm talking so fast to you all, but it's just our Ask Advise Refer. So if you're interested in learning more about how to refer folks to Quitline, you can always reach out to me. We have free trainings available to help you. I will come train you. I will talk to you or your staff. And because our goal here is to just get people in touch with someone who can help them quit, and kind of help facilitate that quit process. So there's no questions now, but I will go ahead and mute and hang around for questions later.
Thank you, Tabetha. Our second panelist is Lori Pietig. She is Director of Cancer Services at St. Anthony Regional Cancer Center. Welcome, Lori.
Thank you so much for having me. Liz, if you're able to share my slides, I will have you do that because, of course, my stuff is a mess again. So
sounds good. Just give us a second over here.
Okay, thank you. As she's preparing that, as Dr. Fremmel said, my name is Lori Pietig. I'm the Director of Cancer Services at St. Anthony Regional Cancer Center. But my career really started in radiology, and I am a registered CT tech and X-ray tech, whom started our program here back in 2016. Perfect, thank you. Next slide. One thing that I do like to know is on March 9, 2021, the U.S. Preventative Task Force did release some updates and recommendations. And why I put proceed with caution is, though those recommendations came out, not all insurance companies had these recommendations up to date within their coverage plan. So I know over the past 2 years that there has been some hiccups in getting coverage for individuals in conversations with our providers about what coverage patients actually have. So that is just a good thing to note, that the age limit did decrease from 55 to 50, and that the PAC year history also decreased from 30 to 20. That opens up screening opportunities for more individuals, but individuals and providers needed to check with their own insurance companies to make sure that those patients were going to have the coverage that they thought they should. Go ahead and go to next slide. It has been proven that early detection of any kind of cancer is key to increased survival. So access is key. And when looking at rural Iowa, the ability to start a CT lung screening program in our critical access and smaller facilities is very, very, very realistic. The 2023, the 2027 cancer plan continues to make cancer screening a priority, and lung cancer screening is one of those new tools that can be very beneficial. These goals and initiatives are not out of reach for rural hospitals. They have to look at their internal resources to build a program to best serve their community. Go ahead and go to next slide. Here are some misconceptions that came out when I was creating our program and I was helping others, is that there is a huge cost. That is not true. There is not a lot of upfront costs when it comes to starting a program. It's more about just time and dedication to that piece of the service line, that you needed to have dedicated full-time staff. That also was not true. We were able to accomplish this with our CT techs and myself as the director in our tracking system. And we all just took a little piece of the pie in order to make it successful. That you need to have a fancy interface or tracking system, that is not true either. Though it does make things easy if you are doing a lot of CT lung screening and reporting, we were able to create our program based off of an Excel spreadsheet and some Word documents that we updated as needed as the program changed. That you need to have complex levels of care at your facility. One question I received one time was, you need to have a pulmonologist and a lung cancer navigator. Also not true. It's all about your referrals. And one thing that small communities do really well with their providers is they understand what they can do internally and they understand what needs to be referred out. So with a nice group of family practice doctors who are on board in administration, this is a very doable program to start. That your system needs to be ACR accredited. And when I say system, your CT scanner. That is also not true. ACR accreditation is not a requirement of starting a CT lung screening program. Go ahead and go to next slide. So let's talk a little bit about our journey and success. So back in 2014, I had a family practice physician who really was wanting to get a program started. And he was my champion. He was the person who kept calling me and stopping in my office saying, when are we going to make it happen? When are we going to make it happen? There were a lot of programs in place, but they were cash-based programs. At that time, CMS and the insurance companies didn't really have set guidelines for screening and billing. There was no easy way to submit data for tracking, which was always key if you're going to start a program. And the NRDR did not have their site set up and running yet. My current radiologist at that time was not interested in being part of a program because he was retiring soon. So those were some of our hurdles to really get the program started. But we knew that a lot of those pieces that we were missing were coming down the pipe. So I just actively watched for information to come out. And once we had some of those key pieces available, we were able to get started. So go ahead and go to the next slide. So it was about 2016. The NRDR was moving forward with launching their website to enter and track data. Now, let me tell you, it did come with some hiccups, but it did work, which doesn't always happen. Our new radiologist that we brought on board when our other one retired was part of a CT lung screening program at his other facility. It was a cash program at that time, but he at least had some familiarity. There were actually billing codes. We had codes that we could actually bill for the service instead of having it to be a cash model. And guidelines were set to help identify who would qualify for a program. Having those guidelines set made it very easy for me to educate and market to the physicians who would meet the standards for the program. We did not veer from those guidelines. Once those guidelines were set, except for the proposed rule changes that came out, we stuck with what those guidelines were. And I looked at the CT lung screening program to be very similar to a mammography program. I never liked to recreate the wheel. The CT lung screening program required you to track, send letters, send reminders, and follow-ups. That's exactly what we were doing with our mammo program. So how could I mimic those workflows and just bring on another concept, which was the lung screening program? And it made it a little bit more manageable when I thought about it in that way. Go ahead, next slide, please. So how do facilities get started? Sometimes your biggest hurdle is just getting administration on board. So talking to administration about the importance of cancer screening programs at a local level, and that there would be a little bit of financial support to get started on the NRDR, but not a lot. Start the conversation with your radiologist and their group. Many of our small rural facilities are being supported by radiologist groups who could already have a program in place somewhere else. So how can you mimic that program or partner with another site that's already doing it? So you have a program that the radiologists are already familiar with. You're just taking on another site and making sure those scan protocols are up to date. Identify a referring provider to be a champion and to be part of the conversation. Provider buy-in is key. They're your referrers. So if you don't have doctors referring to the program, you don't have a program. This is not required, but it will help bridge the gap in the conversation. You could go talk at med staff meetings. They could send out an email and just ask for input from your group of providers who has a patient population that would qualify, and what are they looking for in screening programs. And start researching the registration process and become part of the ACR NRDR lung screening registry. They take everything on their step-by-step on what you need to be required to be part of the program. Okay, next slide. So if you search the ACR and NRDR registry, you're going to see that there are a lot of programs already up in the United States, and I'm very happy to see all of those black dots in the state of Iowa. It's a nice distribution of programs throughout the state, and that we already are well on our way to providing these services to our patients and our communities. The cost in the NRDR is based off the number of radiologists that you actually have signed up in the program. When I signed up, it was a base of 5. We're part of one fee, and if you went above 5, then it was another fee. So what we did with our group is we just identified the 5 doctors that would read our exams, and those are the doctors who we had registered under St. Anthony. Continue updates and information, and there's great tools for question and answer on this website. The website has really grown and become more robust over the last 7 years. As programs have grown and information has been gathered, I do recommend getting on and just evaluating the website to see what they have to offer. All right, next one. What will a facility need in order to be registered? A corporate account and administrator. So you do need to have a point person. I myself, as the director, was the point person and did most of the data entry when we initially started. The total number of reading radiologists, your CT scanner information, your tax ID, and provider information. Okay, next slide. So some key points in building your program. I'm going to go through each of these one by one. So if you just go to the next slide for me. Your scan protocols are going to be set by the NRDR. They're going to give you criteria of which you have to scan your patients in CT, and your CT service provider or your apps professional, they will be able to help you set this up. This is not something you have to try to navigate on your own. You just have to reach out to the company, and they should be able to easily help you set up the train or the scan protocol for your scans. Training for the staff is very simple. These are non-contrast chest CTs. A lot of the training goes into just making sure that the patients are going to be meeting the requirements. If you scan somebody who's a Medicare patient and they are 79, they actually don't qualify for the program because Medicare only goes to 77. So making sure that you're getting the right people getting that scan done. And then use time to educate staff about the importance of this program and ownership of the protocols. This program becomes part of your community, and when you can help your community, everybody's gonna win from that. Okay, next slide. Physician order requirements. We had 2 different types of orders. We had both paper and electronic. We do have some physicians that use our local EMR. It had to, I did get this updated. So it must note that they've had a shared decision-making process, and that's very important. The patient has to be willing to do the scan, and the patient has to be willing to do the follow-ups. If they're not, they're probably not going to be right for the program because they would come back yearly for follow-up exams, or if they would find something, are they willing to receive any sort of additional treatment or any sort of additional testing? They must be between the age of 50 and 77. So some insurance companies will cover it up to the age of 80, but Medicare cutoff is 77. So that's why I put 77 on here. They must be a current smoker or have quit within the last 15 years. The 20-pack history, which is new, it used to be 30, and asymptomatic of cancer. So making sure that they're not having any shortness of breath, or they're not coughing up blood or chest tightness. Those are things that are all very important. And that has to come from the decision-making process with the physician. Next slide. Billing and HIM and authorization. So initially it started as a G code is what was put out, but they did evolve into an actual real CPT code a couple of years ago. If it's a Medicare patient, they do not require authorization as long as they meet the 5 criteria. Anybody who has any sort of commercial insurance or HMO plan, they typically would require some sort of authorization. Work with your radiologist to ensure recommendations and wording is clear in the reports, making sure that you have clear, concise diagnosis codes, and that a CT lung screening is only payable every 365 days. If you scan them at 364, it will not be paid for. So those are all some life lessons that we learned in making sure that we were building our program appropriately. Next slide. Building letters and forms. I put some examples in here of the Word documents. We just populated the documents based off of each patient. So you've got your lung rads 1 through 4. I had a yearly reminder letter and an end of participation letter. So the lung rads letters would go out to our patients. They would be specific in wording if that there was no signs or symptoms of cancer, or they needed to follow up with their provider. The reminder letter would be I'd send them out the month before to remind patients to get their exam scheduled. They'd have to reach out to their provider to get an order. This is not like a screening mammo where you can just schedule yourself. You actually do need a physician order for this, and an end of participation letter. So if a patient would either age out of the program or they would no longer meet the criteria, I would send them an end of participation letter and just state why they no longer qualified. You can work with your EMR, as EMRs can have reporting systems built in, and that can make this process a lot easier. And then we had our eligibility consent form. So that is what's actually up right now. That is what our staff went through with the patient to make sure that, yes, they are meeting all the criteria. And then we put if they had initial screening and any follow-up screenings after that. Next slide. And these are just some examples of some of our lung rad letters. If anybody wanted these examples, I can drop my email in the chat and I can send them your way. You can see that they're really not overly complex. Next slide. The lung rads versions. So these also have evolved. Initially, they did not have all the subcategories. They really were just 1 through 4. And then the subcategories did come into play. So I did have to get creative with some of our letters if a subcategory came into one of the reports, and then I would just have that letter approved by my doctor. Next slide. Tracking results and follow-up exams. Like I had mentioned earlier, I just started in an Excel spreadsheet. Each patient was entered into the website either manually or can be uploaded in a file. We did it manually because we were only doing a couple patients a week. I had a paper folder that I had my follow-up patients in that I would just pull their information out, and I could follow up with their primary care doctor if they haven't come back in for additional testing, or if there were questions on what they were going to be doing next. I always kept the eligibility consent form, and I'd reference back for yearly reminders and end of participation letters. And I did talk a little bit about follow-up exams. And I would add notes in our office communication that this person needs to come back for a follow-up exam, and it needs to be this type of exam based off of the radiologist report. Go ahead and next slide. Provider education. So what some of my learning objectives when I was speaking with our providers was, how do they identify who would be an eligible candidate for a CT lung screening program? The importance of the shared decision-making process in deciding if they would be part of the program and the expectations of that, the process of which to order the CT lung screening exam. It could have been either the paper or it could have been via the EMR. And then what the follow-up process would look like, as long as I felt as if the providers knew and understood the expectations, that that we would have a better result. Go ahead, next slide. And there's lots of tools online for outreach and marketing. You can go ahead and do the next slide. These are all things that are readily available online. And if you have any questions, I've got resources available. That should wrap us up.
Trying to unmute. Thank you, Lori. Our final panelist is Alissa McEowen, nurse manager at Hall-Perrine Cancer Center at Mercy Cedar Rapids. Welcome, Alissa.
Thank you. I'm going to talk a little bit today. So we had an existing low-dose CT program, and we started a program to increase our lung cancer screening rates. Next slide. A little bit about the Hall-Perrine Cancer Center. We're located in Cedar Rapids, Iowa. We are adjacent to, connected with Mercy Medical Center in Cedar Rapids, which is an independent private hospital, is not associated with the larger Mercy Catholic Health Initiatives Network here in Iowa. We have about 60 primary care providers, and we have a collection of various oncology specialties that we work closely with, and we see roughly 1,000 analytical cases per year. Next. We launched a quality improvement initiative. We are a member of COC, or the Commission on Cancer. And so one of our items in 2021 was to kind of look at lung cancer. And when we did a deep dive, our stage 4 lung cancer diagnoses were increasing by 7%. So we were diagnosing lung cancers at a later stage, which obviously increases necessary treatment modalities and increasing the potential for morbidity and mortality. A little bit of background, most of you are probably aware. So the 5-year growth projection, according to Advisory Board for Lung and Bronchial, is 13%. Patients receiving annual CT scans, we know that they are more likely to have better outcomes. And so we really want to get those people scanned and hopefully catch lung cancer earlier, because often it can be cured with surgery alone if it's caught early. Later stages obviously require more treatment modalities. And when I looked at one of our patients with a later, I think it was a stage 3 lung cancer, it was gross charges of over $1 million a year for that patient. And so that included all of the treatments, immunotherapy, things like that. So very, very expensive, and contributing to the financial toxicity for those patients. As a part of our initiative, we looked at data compared to other comprehensive community cancer program hospitals. And so this is 7 hospitals across the state of Iowa. You can see our facility is pretty comparable, but you can see, unfortunately, we would love to have higher numbers on the left side of that curve and diagnose people earlier versus later. But unfortunately, we were trending into the stage 4. Next slide is a comparison of 2010 to 2019 as our registrars looked at the data from our particular hospital. And you can see that 7% increase in stage 4 cancers. So again, trending the wrong way and needing to be looked at more carefully. We started looking at our overall program. We did have an existing program in place, but numbers were on the smaller side. So roughly 60-ish scans a month for low-dose CT. And so we started to look at what the pain points were in our institution. We started talking with providers. Our largest referral source was our primary care network. And so in talking with primary care and reviewing with them at quality council meetings, a lot of them were worried about sending patients for scans because they had heard of billing concerns. They had heard that patients weren't being covered. And so as we looked into that, we actually discovered that in our EMR, we use Epic for documentation. We had some incorrect diagnosis codes that needed updating. And so we looked at that, updated those diagnosis codes, looked at the billing, and found that it was covered under the ACA benefit for most of our local providers and really looked into what we saw locally for insurance providers. There was only one plan that had been grandfathered in under the ACA that was not required to cover low-dose CT, and it was 26 participants in that plan with a very small number who would even be eligible for lung cancer screening. So that really, putting that information out there really helped to dispel that myth and the concern for primary care that their patient would not be covered. In May of 2021, we continued our work and did some IT updates. We all know that, IT is kind of the saying is garbage in, garbage out. And so if you don't have the right documentation in your EMR, unfortunately, it does not trigger the right things and will not provide the right information to insurance. So we updated our smoking history. Unfortunately, in Epic, the lifetime smoking calculator, which calculates the necessary pack years, was in a different location. And so that was being missed by a lot of staff, and we were not grabbing the pack years into that patient's history. So did some education with that. We were not able to combine. We're still waiting on Epic to make that change for us, but hopefully that will come in the near future. And then our EMR offers the category called health maintenance. And what that is, it's kind of a one-stop shop for providers to look and see, okay, my patient meets this age criteria, this gender, these organs and things like that. What are they eligible for? And so they can easily look and see, okay, this patient needs a mammogram, low-dose CT, things like that. And lung CT had not been a part of that before, so it was a really nice visual to help increase awareness for our physicians. That took a little bit of time. So in July of that year, we moved on to rolling out some education. We are fortunate to have a physician champion who attends quality council meetings with all of our entire PCP network each month. And so sent out some information with that. Also did some education for staff across the system on documentation. Reviewed the fact that it's actually a category B recommendation. So yep, it's right on par with MAM and colonoscopy as far as a recommendation. And then again, the monthly quality council meetings. Bulk screening. So really where we've seen some success, there are two parts to our success. So one is bulk screening and the other is really just information and education. So I'll talk a little bit about what bulk screening is. We started this, there was a group, actually our cancer center director, Jared Cast, started this program with GI. And so we started looking at screening and created a multidisciplinary group of departments all across the hospital, pulled in a lot of teams that maybe you wouldn't necessarily expect to look at this and to begin talking about this process. We connected with some of the clinics, did some bulk ordering education. Next slide. And what bulk screening is you use your electronic medical record to pull in, you have a list of categories. And so again, you're looking at age, all the different screening criteria. So for lung, obviously you're looking at age and smoking history and a few other things. That generates a patient list that meet those criteria within our system. And then we can use IT and marketing elements to contact those qualifying patients who are overdue or maybe non-adherent for a screening element. So the way we started, you have to start small and prove your concept, right? So since it was in GI, we started with some clinical staff in the GI clinic. And once we created that list, they would get a letter or a MyChart, which is an app that our patients are able to use, a message saying that they're due for something. If they didn't call and respond, then the nursing staff in that clinic would call the patient 2 more times and try to get them to schedule if they were willing and able. Had some success with that. So was able to move it to our clinical improvement department and incorporated mammography into that as well. And we do allow walk-ins. So that was a slight change we made to that process. Either the patient would go ahead and schedule or walk in. When we were ready to do lung in December of 2021, we needed to start, the clinical improvement department wasn't really ready to take that on. So our wonderful oncology nurse navigators, I think one of them is on this call, Jessica Steppens, they stepped up and they started calling patients for one of our smaller outreach clinics. And actually were really surprised. They expected to get some resistance from these patients who maybe had never had a screening. Patients were willing to talk about it. They actually, a lot of them had never heard about low-dose lung CT screening and that they could qualify for it, which really has fueled my passion around education and advocacy. And then once we were able to have some success there, we have moved it to its final team with our prior auth and billing team. You can see our rates, and I think that is shows the success of the program. In February 2021, we started the project. We were in the 60 to 80 per month range, and then all of the different little stops we had along the way. We were really excited in February of 22 when CMS adopted the updated guidelines and we could expand our program. And then May of 2022, we had worked through all of our primary care clinics with the non-adherent patient list. And then you can see the rates continued for a while as patients move through that medical decision-making visit and then actually getting the low-dose CT screening. So still something we're going to track and keep an eye on. Our successes with lung in particular, so bulk began in December of 21. We've had about 3,200 patients contacted regarding low-dose CT screening. About 2.5% have made it all the way through the medical decision-making visit and then also the screening. A higher percentage have had that visit and then not completed the screening, so that's something we're currently looking at to see why that's happening. And then really a much higher percentage have just had the CT screening ordered and completed, just I think due to increased awareness and hopefully documentation in the system. From screening alone, we've had 5 Lung-RADS-4 ratings, which resulted in an oncology consult. We have not diagnosed any cancers yet, which I'm glad we're continuing to catch those early. As a system, we went from a 23% to a 40% screening rate with our eligible patients, which I think was a huge success for us. In Iowa, I think the rate is at roughly 10-ish%, and it's lower nationally, maybe 5 or 6%. So we're excited about that. We also started a multi-D nodule clinic with pulmonology in March of this year. And then we just this week started using a new biopsy technology to get those kind of harder to reach nodules in order to diagnose patients a little bit quicker. It wouldn't be a talk without talking about lessons learned, right? You don't go through a process like this and not have some hiccups. So we definitely had those, and I just want to be transparent about that. At a point in our process, I really had hoped to create a streamlined clinic where the patient could go and have that visit and then also get their CT, just walk down the hallway, get that CT done same day, really convenient, really easy to impact that all within the visit. The challenge was providers, PCPs really wanted to own that because they know their patients. And also, what do we do with the management of those incidental findings if there was another finding on that CT that then need managed? So unfortunately, we're not able to do that. But just a lot of education around bulk screening, a lot of good conversations with people throughout the system on what that could do for their patients and actually help them utilize their time more wisely. And then again, like I talked about, the opportunities to convert that visit to the screening. Future state, these are all the things that we hope to continue to look at and do and grow our program. So really want to manage those incidental nodules that are found maybe within our ED, patients who come in with various things and that is found there. So hoping to get something rolling there shortly. We want to reach out to independent PCPs and community hospitals that are not a part of our network and help them with their program if able. Explore free and reduced cost screening. So looking at some potential partnerships with our foundation or other grants or things to do that. Marketing, and continued EMR work, working with the Iowa Cancer Consortium and the screening group there. And then looking at compliance of that continued annual CT. So we hope to get patients when once they're in the system to continue to do that. So that is my presentation. I think the takeaway for me is, if you're looking to start a program like this, really look at the pain points. Why isn't it getting ordered? So for us, it was some work with the PCPs and our system itself.
Thank you, Alissa, Lori, and Tabetha. We will now open the floor for any questions or comments. Please feel free to come off mute or to put your question in the chat. And I can start us off. If you've seen, anyone can take this question, if you've seen resistance from eligible patients to get screened, what reasons do they usually have?
I think go ahead.
For us, it would be the fear that they're actually going to find something. to have to make and change those, the thought process of making those lifestyle choices and making those changes. That would be some of the hesitance that we would see.
We've heard that as well. Sometimes it's transportation from some of our outlying clinics. So there's a variety of factors.
We have a few more minutes if anybody has some additional questions for our panelists.
It looks like there's a question in the chat. And I know, thank you, Tabetha, for kind of answering those as we go. And let's see, my chat got moved. Okay. Did anybody else on the consortium team see that new question that came through?
I actually saw it. It was
Thank
from
you.
Jackie. Yeah, no problem. So yeah, we actually do have lots of data on the harms of chewing tobacco. It definitely is not as much of a used product as, you know, smoking cigarettes or e-cigarettes, but we do definitely have the data to support it. We have the most recent data from Burfus. I just didn't touch on that today. I did put my email in there though. So if you're interested in more of that specific data, please send me an email because I would be happy to forward all of that information with you. And one more thing, we do have local contractors that are doing this work, tobacco prevention and control work at, you know, the local level. So the boots on the ground folks working in all 99 counties. And a lot of those working in those rural counties are, you know, working specifically on smokeless tobacco products. So great question.
We have 1 minute left. If anyone has an additional question for our panelists. I guess one question are there any recommendations for lung cancer screening due to known radon exposure?
Unfortunately, none that I'm aware of.
All right, well, that's all the time we have. Thank you again to our panelists, and I'll now turn it back over to Liz.
All right, thank you everybody for that great panel. Let's see, we're gonna take our second 15-minute break now.
All right, welcome back from break, everybody. My name is Rachel Schramm, and my pronouns are she and her, and I'm the program manager here at the Iowa Cancer Consortium. I'm very excited to introduce our final session of the day, prostate cancer among African American men. We have 3 speakers today, Dr. Paige DeRosa, Bridget Saffold, and Omar Leflore. Each speaker will give about a 10-minute presentation, and following that last presentation, we'll have a 15-minute Q&A led by Kelly Pietig. As we listen to the presentations, please feel free to enter your questions or thoughts in the chat for the speakers. We'll make sure that we revisit them at the end of the session, and there'll be time to come off mute in the Q&A. So our first speaker, hailing from Queens, New York, we have another staff member who's also from Queens, is Dr. Paige DeRosa. Dr. DeRosa is a urology resident at the University of Iowa Healthcare with a focus on health equity. She received her medical doctorate at the State University of New York, Downstate Medical Center at the College of Medicine in New York. Welcome, Dr. DeRosa.
Thank you so much. I'm happy to be here with everybody today. Thank you for joining us, everybody. So I'm going to speak a little bit about prostate cancer screening, diagnosis, and treatments. We can move on to the next slide there. So first of all, wanted to talk a little bit about prostate cancer screening. We use the prostate screening antigen PSA blood test very commonly as a tool for screening. And I wanted to highlight some of the differences between different screening protocols. I have highlighted here the American Urological Association, which is the guidelines that urologists look to for guidance. Most recent published guidelines are actually about to change over the weekend, but I think the overall gist will be similar. That we recommend against PSA screening in men under age 40. We do not recommend routine screening in men between ages 40 to 54 at average risk. And for men that are younger than age 55 who are at higher risk, and that might be Black men, that may be people with a family history of metastatic cancers, prostate cancer screening decision making should be individualized. And this can be rather controversial. So that's why I wanted to highlight that there's some other guidelines at play. We have the United Services Preventative Services Task Force. They advocate starting prostate cancer screening at age 55 to age 70 with shared decision-making. You may have heard in the past they recommended against prostate cancer screening, but that guideline was updated in 2018. And I think we're going to see some overall flux in these guidelines going forward, especially after the AUA makes their decision-making. But mostly, I want to highlight that there is an emphasis on shared decision-making. And in order for that to happen, both parties need to be well informed on the risks and benefits of screening. We'll go to the next slide. So if you have a prostate biopsy, that's the next step in diagnosis of a prostate cancer. Just to demystify the process, there are two main approaches to a prostate biopsy. Mainly, they involve a transrectal ultrasound, and we perform a transrectal ultrasound guided prostate biopsy, where the biopsies are taken with a needle through the rectum, or transperineal, where you have an ultrasound in the rectum visualizing the prostate, but then you actually take the biopsies through the skin of the perineum, the area between the scrotum and the anus. And so here's a photograph of what this looks like, as if we could see through this person and see the needle entering the prostate. And so it's a relatively quick procedure, most cases outpatient, and in some cases does require anesthesia, and that's discussion with the doctor and the patient. Go to the next slide. We have other technology to help us optimize our prostate biopsies. So for example, here at the University of Iowa, we often perform MRI guided prostate biopsies. We call this MRI fusion. So we use both the ultrasound, and that's here in this my left-hand corner, where you can see the ultrasound of the prostate. And then we fuse that with the help of the radiologist with MRI images that have been obtained of a patient's prostate to better target any specific prostate lesion that we may have interest in. And so you can see here, the urologist has taken a biopsy of this area with the very helpful target sign. Okay, we can move on to the next slide. I wanted to go through treatment options. And so you might say, well, there's a lot of different kinds of prostate cancer, and that's 100% true. And there's just as many kinds of treatment options. If there's a person diagnosed with prostate cancer, there are several treatment options depending on the nature of the disease. If you have a lower risk disease, oftentimes we offer active surveillance, which in practice usually means that we're checking your PSA and doing biopsies, usually on a period of 1 to every 2 years, sometimes 3 years, depending on the provider. For more intermediate risk disease, if it's favorable, so a little bit lower risk in terms of a moderate category, we offer active surveillance, radical prostatectomy, or radiation. For more unfavorable, intermediate, or higher risk prostate cancer, most folks will offer a radical prostatectomy or radiation therapy, plus androgen deprivation therapy, which suppresses an individual's testosterone. And so I have these all listed here for you, so you can see active surveillance, radical prostatectomy, or removal of the prostate gland in its entirety, brachytherapy, which is seeds of radiation into the prostate, external beam radiotherapy, androgen deprivation. And then in some providers will offer, for specific patients, cryotherapy or high intensity focused ultrasound. And there are specific advantages and disadvantages, indications and contraindications for all of these therapies. And there is some good news in that none has been definitively proven to be superior in terms of quantity or quality of life. So certainly whatever is right for that individual person, we can say is beneficial and might not change the overall outcome. Okay, and so we can move on to the next one. A lot of people often have questions about robotic prostatectomy. And so the majority of prostatectomies are now performed with robotic assistance. This is an image of what it looks like if you're a surgeon sitting at the console and you are at the point of the surgery after we have, looks like they've removed the prostate here and they are doing bladder neck reconstruction. So here in this handy dandy comic, we have the area that we're removing, the prostate, a little bit of the bladder neck here, the prostatic urethra here, and the seminal vesicles. and then we reanastomose the bladder to the urethra. And so now this person does not have the prostate any longer, but instead has this new connection. And so after the prostatectomy gives us a lot of good information. It gives us pathologic criteria that we can use to discuss with the patient about their particular disease. And so now that we've spoken a little bit about screening, diagnosis, treatment of prostate cancer, I'd like to segue into the rest of our discussion about disparities in prostate cancer. I'll move to the next slide there. And so a key issue is the tremendous disparities regarding the mortality rate for Black men. Black men are more likely to die of prostate cancer than white men. And unfortunately, they're in the United States more than 1.5 times as likely to be diagnosed with prostate cancer. And the number is more than twice as likely to die of prostate cancer as it stands today. You can go to the next slide. And so the question is why, and this is an important question. What can we do? Cultural factors can be at play, including some mistrust of the healthcare system from longstanding relations, poor physician-patient communication. Sometimes folks don't have enough information on prostate cancer and treatment options. There could be a fear of a prostate cancer diagnosis or perceived stigma of having this disease. There's also geographic trends and racial disparities, so it may depend on where you live. Economic factors are certainly important in disparities in prostate cancer in general, including cost of care, recovery time, cancer debt. And then a big thing that I think we're all interested in here is racial diversity is often lacking in clinical trials, especially genomic and precision medicine studies. So there's lots of reasons why this may be, that there are Black men who are largely underrepresented in prostate cancer trials. It may be that folks are not aware that they have the option to participate. There may be that people in the research teams are not diverse, and so there's not good representation. There's not as much outreach. And then could be some bias with healthcare providers not to offer clinical trials or clinical research to the patients that they see who are Black men. And so the next slide here, what can we do? So there's a lot we can do about it. I think number one is acknowledging the impact of structural racism and how bias and the underrepresentation of Black folks can be embedded in our systems. And it's important because underrepresentation in clinical and translational research may have us getting risk calculators and biomarkers that aren't validated in Black men, and then leading to poor treatment decisions in that population. What we can do is we can include funding to include minority serving institutions. We can increase Black representation in clinical trials and translational research. And I'm excited to hear our next speaker talk about community engagement and collaboration to promote shared ownership of clinical research between community leaders, community providers, and patients, prospective clinical trial participants. Basically, we need everyone to know that there are barriers that Black men are experiencing to get into trials and to get prostate cancer care. More diverse healthcare providers are also very important. And let's empower Black people with a prostate, to be involved in their treatment. And so that's what I'd like to share with you this afternoon. And thank you all for listening.
Thank you, Dr. DeRosa. All right, our next speaker is Ms. Bridget Saffold. Bridget is a nurse supervisor and executive director of Focus on Diabetes. She serves on the Black Hawk County Cancer Steering Committee. With health promotion and disease prevention as a top priority, Focus on Diabetes initiated Project Health as an extension of their current community engagement activities to address the disparities in prostate cancer. Let's give a warm welcome to Bridget.
Thank you so much. Am I unmuted? Can you hear me?
Yes, we can.
Okay, perfect. So thank you so much, Dr. DeRosa, for sharing that great information. Some of it kind of overlaps a little bit, but I'm glad you brought up some of those disparities that you already identified. And so just as a little bit of a recap, we know that African-American men are more likely to be diagnosed with prostate cancer and at least 2 times more likely to die from prostate cancer. So they technically are dying from a disease that other people are living with for years, or they're dying with because they're dying of other diseases. African-American men are being diagnosed with prostate cancer at earlier stages, and they suffer from more aggressive disease. And in the state of Iowa, prostate cancer has one of the greatest disparities in incident and mortalities between Black and white populations of men. The next slide, please. So as we heard from Dr. DeRosa, there's a lot of common themes that are possible barriers to prostate cancer screenings and attribute to the causes for increased mortality rates in prostate cancer. That could be anything, like she said, from a lack of access to care. That could be inadequate knowledge of screening recommendations. That could be fear of prostate cancer. And we know specifically for prostate cancer, the stigma that goes along with digital rectal exams. And then even in Black communities, kind of the stigmas that go along with cancer diagnoses and the way that that information is not always shared amongst family members. That could be medical mistrust, and that also could be poor communications between the patient and their providers. Next slide, please. So over the past year, I've participated with the Cancer Steering Committee here in Black Hawk County. We spent a lot of time reviewing data about cancer, not just prostate cancer, but other cancers like breast cancer, lung cancer in our community. And one of the things that I did learn was that Black men in Black Hawk County has a higher prostate cancer incident and mortality rate than the white men across the entire state of Iowa. I mean, that was pretty alarming to me alone, but they also have higher incidence of prostate cancer amongst all age groups. Next slide, please. So knowing this information, Focus on Diabetes, which was the nonprofit that I helped co-found, we initiated Project Health, which is a prostate cancer initiative to engage African-American men to have conversations about family health history, provide health education, and to promote routine screenings. In the initial phases of this project, we did a little research in Black Hawk County to see if these common narratives that we heard align with the population that we are serving here. So here's a few things that I learned from that research that we did. Next slide, please. So the first thing we looked at was access to care. And when we look at that, the first thing we were looking at was insurance coverage, because we know people that are underinsured or uninsured are less likely to seek out medical care. They just probably are not going to the doctor, but they are usually seeking care at places like emergency rooms, urgent cares, and things like that. And we know they are more at risk for poor health outcomes. The second thing that we evaluated was primary care services, because people with primary care overall have better health outcomes, fewer disparities, and also lowers healthcare costs. So next slide. So in Black Hawk County, 95% of the men who participated had medical insurance, which I think this kind of makes sense for the community we live in, because we have a lot of large industrial employers like John Deere. We have Target Distribution. We have places like UPS and FedEx, Tyson. So those are just a few of our big employers, but they employ a lot of people. 90% currently have primary care providers, and 80% of those who participated seeing their providers annually pre and post-COVID. So I thought those were pretty positive numbers from our community, that they are seeking their healthcare and they are seeing their providers annually. So next slide, please. So prostate cancer screening recommendations, as we already heard, a lot of those recommendations call for shared decision-making. So this is kind of a patient-centered model that encourages individuals to participate and play a bigger role in making healthcare decisions for themselves. So that kind of includes two things. That includes a provider that's willing to explore and respect what the patient wants, but that also includes the patient to be armed with good information. Next slide. So 48% of the men in Black Hawk County knew little to no information about prostate cancer. 73% said they heard of prostate cancer, but didn't know prostate cancer screenings, but they didn't know much about it. But when we asked them what the primary screening test for prostate cancer, 63% chose rectal exam. And we saw with Dr. DeRosa's presentation, she spoke about the PSA screening, which is a blood test. And I think when men fear that rectal exam, maybe they don't talk to their doctors about prostate cancer screening because they fear having that test. But if they knew that the PSA, which is a blood test, was an option or a test that was available, would they then bring it up more readily to their providers? And I think we need to talk about that more, because if they're already seeing their doctor, they're likely having blood tests done, but they just don't know. So the next thing is a medical mistrust. And when we talk about medical mistrust, often we hear of it related to slavery and a Tuskegee syphilis study. But I really want to challenge that thought and that narrative and swing our emphasis into the present so that we can have more effective interventions and make transformative changes in healthcare. So next slide. So to evaluate medical mistrust, we asked, where do you go to seek health information? And if you look at that slide there, you see 79% are seeking their medical advices from their doctor. And on the next slide, we asked what the trust level was with the healthcare system. And if you group that orange section with the blue section, you see that they actually have quite a bit of trust in their medical system. So when I look at this, I realize that medical mistrust is based mostly in poor communication between that patient and provider and personal experiences that people and their family have. And so medical mistrust isn't what we thought it was in the past. So the next slide. Race is absolutely a factor when we think about prostate cancer, and we see that African-American ancestry plays a big role in prostate cancer diagnosis, and it plays a huge role in when screening should happen for Black men. But also, we don't want to forget those genetic factors related to prostate cancer. So I've talked quite a bit about family medical history, about the importance of that, but not only do we need to know, we need men to understand if they have a first-degree relative that they're more at risk, but also if they have a mother or sister or someone with breast cancer, that they have an even higher risk of breast cancer. So just understanding that genetic line of disease will actually help Black men kind of have better conversations and participate in their care. So the next slide. We want to just remember that all the participants were African-American men. 79% of them were over 40 years old, and 54% of them have not yet been screened for prostate cancer. So just a couple of gaps that I identified was those screening recommendations that Dr. DeRosa talked about. They're kind of confusing when you look at them in total. I think it causes a lot of missed opportunities for providers to initiate those conversations about prostate cancer screenings. And even the men in Black Hawk County who sought that healthcare from their providers and their doctors just did not receive the quality of care that they deserved. And secondly, the lack of awareness and education and the lack of knowing family medical history not only makes it difficult to participate in making healthcare decisions, it also contributes to a widened disparity gaps in healthcare. So the last slide, the moral of the story for me really is early detection is key for treating prostate cancer with the intent to cure. And that is what we are kind of all about with Focus on Diabetes. We think it's highly important to focus on family health, but we really want to engage men to have conversations with their relatives about their family medical history, provide health education to empower men to become self-advocates and promote routine screenings for generations to come. So thank you so much for your time.
Thank you so much, Bridget, for your presentation. Now we're going to move to our final speaker, who is Omar Leflore. And I would like to point out that he is a Tampa Bay Buccaneers fan before Tom Brady. So if you like the Tampa Bay Buccaneers or another team, shout it out in the chat. But Mr. Leflore is a prostate cancer survivor living in Waterloo, Iowa. He was diagnosed with stage 3 prostate cancer at the young age of 36. Thankfully, his cancer did not spread and he's been in remission since 2019. Omar and his wife have 6 children. So please go ahead and give a warm welcome to Omar. Take it away.
Hi, how are you?
Good.
Okay, so I'm Omar Leflore. I was diagnosed with prostate cancer at 36. I didn't know what I was going to do. So I'm from Waterloo, Iowa, and I went to a lot of the hospitals here to try to get help. And they just kept pushing me off, telling me they're going to actively watch it. I had a lot of blood in my urine. So that was the main reason that they transferred me to urology. And I didn't feel safe, and I didn't feel like comfortable. So I went to Iowa City, and I got more answers in Iowa City than I ever did in Waterloo. Is awesome. He did my he's my doctor, but he did my surgery and everything. They completely removed my prostate. I did a little bit of radiation, and I cannot manage erections by myself. I have to use pills or whatever. But I mean, I don't care. I'm alive, so that's not really the issue to me. But grateful for the road and journey I took, because I actually had a couple other people that had prostate cancer, and they had a ton of questions, and I was able to answer that stuff for them. So it was really, really good.
Omar, can you tell us a little bit about how your diagnosis affected your daily life with your family, like with your kids, and just kind of when you were going through your treatments and stuff?
It kind of took a toll on me, but if anybody knows me, I'm like a super happy person. I'm never negative or anything like that. So when I found out, I was really negative and just grumpy and not myself. And funny situation. My 6-year-old daughter told me that, "Dad, you're acting really crabby lately. What's going on?" So I had to get myself together for my 6-year-old, or for all my kids, actually.
Did you share with your kids about your diagnosis and what that meant to you?
Yes, because I have a son that will actually be 20 in June. So he needs to know all this stuff that's going on so he can be proactive in his life. And if something happens to him, he can catch it before it spreads.
Was there any?
But my kids did not take it well.
Did you ever consider counseling or anything like that while you were dealing with cancer, and while your kids were kind of trying to cope with maybe the way you felt and how you were a little bit different during your journey? Did you ever consider anything like counseling for them or for yourself?
Yes, I actually went to a psychiatrist because it just changed me so much. And actually, I had a stent of bladder cancer too, but they removed that in Mayo, so that's like a total different deal. But yes, I went to a psychiatrist, just talked to them, tell them everything that's going on, and I feel a lot better about it.
So tell us what's going on today. Have you been able to kind of get past some of those feelings and then kind of get back to what feels like a normal life?
Yes. Yes, for as normal as I can get, yes. Because I still actively have the blood in my urine still, that actually never stopped. So we're on that journey now to try to figure out where it's coming from. But yeah, I'm as good as I can get. Yes.
So just dealing with your initial diagnoses, was that local providers or was that after you were referred to the university?
That was after I was referred to the university. So I went, okay, so the blood started in 2017, and I was finally able to go to Iowa City July of 2019. They found it in like 2 months, and they did the surgery October of 2019. So Waterloo could have found it if they would have tried, but they didn't. And Iowa City, I swear I felt like a lab rat. They were like sending me here, sending me there, but they found it. Like they actually cared enough to go through all those tests and back and forth. And I mean, my hat goes off to them. Anyone in healthcare, anyone in Iowa City, I love all you guys.
Did that change any of your trust level with your local healthcare providers?
Yes.
Like how has that
I do not
changed?
have a local doctor. Yeah, I don't, my wife or I don't have a local doctor. We go all the way to Iowa City just to go to the doctor. Hour and a half, but for peace of mind, I'll take it.
Yeah, that's interesting because we just were reviewing some information about people in Black Hawk County and how they had more confidence in going to some, not maybe local providers all the time, but more confidence in going to like a Mayo Clinic or going to the University of Iowa and seeking care and just trying to understand what is that related to. And I think the overarching issue is exactly what you said and what we discovered earlier was those experiences that you have with your local providers really shape how you move forward with your care. And I think that was kind of a big highlight for us, that if you don't have that trust in your local provider, or you don't really have that relationship with a primary care, how people really do feel more confident in going somewhere like to the University of Iowa.
I mean, I would recommend it. I'm not trying to be biased or nothing. I'm just being totally honest with you all. I would recommend going to a bigger university or anything if you really want answers, because they'll put you through a lot of hoops to not go.
Well, we appreciate that, Omar, for your honesty. And how is your wife doing with dealing with just overall dealing with you having cancer? You guys are pretty young. You're a young couple, young parents, and things like that. Just how was her experience in dealing with cancer with your diagnosis?
She was really nervous. Yeah, she's a worrywart. So, but no, she was there every step of the way. She was nervous. She was pushing me to get up and get energy. Like on some days I would do radiation, I wouldn't have any energy to do anything, but she would push me to get up and just like go get a little exercise or go get a bite to eat or just any little thing. So I would try to start getting back to my life.
Yeah, so this is the last thing I'm gonna ask you, and then I'll leave it to everybody else to ask any questions if they have any. But can you think of anything that could have been provided to you that would have helped your journey, make it a little bit easier? Any support that you could think of? Anything as a healthcare professional that we could have provided you that would have helped you along the way?
Not really. Well, in Waterloo, yeah, but not in Iowa City. They were on it. Maybe like a counselor for you to talk to when you get stressed and stuff like that, because you being a male and not being able to get an erection, it's hard on you. So, but I'm alive, so that doesn't really matter. We'll get through the rest of it later on. But some men can't handle that. And I know I've talked to men who said they would rather die than not be able to use their penis. I was like, are you serious, bro? You cannot be serious. That cannot. So everyone's different, and it's tough for sure. But
yeah,
just someone to talk to, like an outlet, so you can get your feelings out, stuff like that.
Thank you for that, Omar.
Oh, sorry, Bridget.
No, go ahead. I was just saying thank you for that.
Well, and I was just going to echo that same thing. Thank you so much for your vulnerability and for sharing your story and your experience with us. We talk so much about statistics and, look at population level information, and really what we're hearing from you is really at the heart of what is important about cancer control work. So thank you for being here. Thank you for being so honest and open about your experience. Really appreciate it. And thank you, Bridget, for your presentation, and thank you, Paige, for your presentation. And we do have time for some group Q&A if everybody is up for that. Folks can drop questions in the chat, or you're welcome. I am going to ask you to use your raise hand function, just so we can let you know when it's time to come off of mute, but you're welcome to ask questions that way. And I'm actually going to go first, if that's okay. And Omar, it's another question for you. I was so struck as a parent when you said you have 6 children. That I just can't even imagine, to be honest. And Bridget asked the great question about, did you talk to your kids about cancer? I'm curious how you talk to them or plan to talk to them about cancer in the future now, based on your experience. Does that change, or has that changed? What are your plans for talking to them as they grow into adults?
So me, I'm really not a sugar coder. So I kind of just, as it comes in, I'll just talk to my kids about it. And if it's really severe, we'll sit down and have our family meetings on Sunday. So I'll just add in there that, dad's got to go have another surgery, or dad needs to do radiation, so like when I was doing all that stuff, they were my strength. So when I was there sitting in those rooms cold, I would think of them, and that would get me through.
You think differently about will you encourage them to face healthcare or to interact with healthcare differently based on what you've been through?
Yes. So my children don't have a physician in Waterloo anymore. But my children go to Iowa City as well. So when that happened to me, it completely changed my life. Everyone in my family goes to Iowa City for doctor. So yes, we will be proactive on that.
So much. And George Weiner, Dr. George Weiner, I see you have your hand up.
Sure. Well, first of all, Omar, thank you so much for sharing your story. The guidelines are incredibly complex as to who should get screened and how patients should be managed. And they are because the science is continuing to evolve. How do we go about making things simple for patients when we know the background information is so complicated that it's really difficult to tell a very clear story about what the various options are? I don't know what the answer to this is. I had my own prostate cancer experience, and being a cancer doctor, I knew exactly how complicated the data was. And so, but I can't imagine having to explain to someone who's likely very smart, but has never heard of prostate cancer before. It's just incredibly difficult to do. And just would appreciate any suggestions or comments anyone has in that regard.
So for myself, really on a public health arena for me is really more of teaching people risk factors is important to me, to just get them to understand, not the fine details always of it, because I do believe that those details come within going to your doctor and kind of initiating some of those conversations. But I think on a patient level, if they understand basic disease and what those risk factors are, so they can evaluate, now, am I at risk for this, but that I can also go to my doctor and bring up the issue. I work with a urologist, and I asked him, I said, if a patient walks into the office and asks you about prostate cancer and if they should be screened and put that in front of you, what do you do? And he said, well, I'll be kind of forced to talk about it. And so it at least initiates conversations to where then the doctors are evaluating it at a time where maybe they would not have brought the issue up. And now, that's kind of what it is for me in advocating and educating community members, is not to kind of get really in the weeds and fine details, because I believe if we making sure that they're getting to their doctor and they're kind of asking some questions and initiating a conversation, that the doctor then evaluates and assess to let them know, is this then something you should do, or let's talk about it at least.
Thank you.
Kelly, this is Dick Deming. I can't figure out how to raise my hand.
Yeah, oh, yes, go ahead.
I think so. Thank you for letting me ask a question. And this is primarily for Dr. DeRosa. And Dr. DeRosa, I'm Dick Deming, and I'm trained as a radiation oncologist. I am a 70-year-old Caucasian cancer doctor, and I've never had PSA screening. I am a big fan of active surveillance, and a question that I would have is comments you might have on the March New England Journal of Medicine article. There was a randomized prospective study of 1,500 cases in Great Britain. The UK is the only place probably could do this, a randomized study of organ-confined prostate cancer. A third of the patients had radical prostatectomy. A third of the patients had radiation therapy. A third of the patients had active surveillance. And after 15 years of follow-up, no difference in survival. Do you see in the urologist world more embracing of active surveillance as opposed to kind of the default of treatment, kind of the American way of treatment is better than active surveillance? So I guess that question is, you're still in training, PGY4. I've seen more embracing of active surveillance, and I'm curious, in your education and training as a resident, are you learning skills on how to communicate in a positive way to patients? There's one thing about saying, well, you could do active surveillance, but that's really doing nothing. And in the meantime, your cancer could spread and you could die. But to actually, in my experience, a patient's never going to want to do active surveillance unless they have a provider that speaks of it in a positive way.
Right. And I understand what you're saying there. I think, first of all, yes, active surveillance is certainly being embraced by the urologic community. And I think that's one of the reasons why we can say that the United Services Preventive Task Force upped their recommendation for prostate cancer screening, because they recognize that one of the risks of screening is the overtreatment and burden of treatment. And so now that we've embraced active surveillance more, that harm is lessened. And we actually just had a visiting professor who spoke all about active surveillance and the fact that just in the last 10 years, folks that we would have removed prostates in, we're now putting on active surveillance. And I think the way that you communicate about that plan really affects whether or not people are going to buy in and feel comfortable. Exactly like you said, if you say, we're just going to sit here and every so often we'll check your PSA, people might not feel so comfortable. But if you say, like, this is the data that we have, we understand that in this way we can minimize any potential harms of treatment, but maximize your overall quality of life while also keeping a close eye on your prostate cancer, then I think you have a more productive conversation, because I think that's really the story there.
Thank you.
Thank you.
Questions?
This is Rachel. I just had another question for Omar. Can you talk about just what the impact of coming down to Iowa City for appointments was, just like on like your work life, your family life, and how do you budget for car and a gas to make these trips?
So yes, I burned a lot of my savings doing that way, but I wouldn't change it. It was really tough. Gas was really expensive. And also I was laid off. I mean, I wasn't laid off, but I was off on disability as well because I had my surgeries. So it was really tough. My wife, she supported a lot of that while I was down.
I have another quick question. Dr. DeRosa, you referenced changing screening guidelines. I was wondering if you could say more about that.
Yes. So this weekend is our annual American Urological Association conference, and it's been publicized that they're going to update the screening guidelines. Things that I think we're going to see is more discussion of personalized, like precision medicine tests and where to use them, and more about shared decision making, and a little bit more on like the timeline for when to screen. So unfortunately, we don't have all the guidelines yet. But next week.
Yeah, thank you. We'll be sure to watch for them. Other questions? Feel free to be brave and could just come off mute. Last call. Other questions? All right. I want to thank our three panelists again so much. Just appreciate your time and your wisdom and your stories. Thank you so much for being here. And with that, I will turn it back over to Liz Horton.
All right, thank you, Kelly, and thank you so much, Dr. DeRosa and Omar and Bridget. That was really interesting, and again, so good to remember that the real people involved with cancer diagnoses. So thank you so much. Just want to thank everybody for spending your afternoon with us today. Please take a moment, either now, well, now would be preferable, but go to canceriowa.news/spring23, and that is the evaluation for our meeting today. And we will be sending out an email follow-up. We'll have a recording of today's meeting, as well as some resources that were mentioned and everything like that. We hope to see you all this fall at the Iowa Cancer Summit. More details will be coming soon about that. And then tomorrow we have another great webinar for you called Strategies for Equitable Access to Cancer Clinical Trials. That will be put on by our Research and Clinical Trials work group. And there will be a link in the chat for registration. It's free, but you do have to register. And with that, I saw somebody ask in the chat about a date for the summit coming soon. So we'll email that out as soon as we have a date for you all. But again, thank you so much to everybody for attending and to all of our speakers for today. And with that, we can adjourn the meeting and hope that you all have a great rest of your Wednesday afternoon. Thank you so much.